Hey guys, feels like it's
What's
been a while. Feels like it's been a while since we've done this. I know y'all are in this long 6-week module. So look, a few more days left. All the time and effort you put in, try not to think about it. Just put your head down and it'll be over before you know it. I know this was a long module. We're gonna split this review up into two. So today we'll cover GI. Lindsey's going to go ahead and do the micro stuff. She put some slides together. Then I'll go ahead and go through my notes for the pathology, and then I'll do the pharm stuff with you guys too. We'll try to keep it to about 2.5 hours. The review tomorrow is at noon, and we're going to Lindsey's going to cover ER. Then I'll go through the micro stuff. That's the plan. Just a heads up for you guys. Next term, so I'm going to be down here studying for STEP. So I intend on continuing to do the reviews. Kishore is going to help me with some of the lower term reviews. But for you guys specifically, after you get through the neuro module, term 5 is very much cumulative. So it really works out for all of us because I'll be studying for STEP. So we'll take more of like an umbrella approach to the topics. I'll look into it and see, maybe we'll do question-based sessions or something like that. But anyway, don't feel like we're going to leave you guys hanging. Lindsey has her own plans. She can go through that with you guys. But just so you know, we're definitely looking forward to continuing this going for you guys. It's been definitely a two-way street. I think Lindsey could attest to this. We've both benefited greatly from doing this with y'all. We've learned a lot in our own right. So we're definitely happy to help. So Lindsey, floor is yours.
Hey guys, so we have some path and micro slides for you guys today. Brady's going to go through his notes, so we're not going to go directly through the PowerPoint slides, but you have that. I condensed it down for you guys. I organized it differently. You guys know that I go through and I make my own notes and I go off of first aid, so it's organized a little differently. It's condensed down from the slides you have from SGU, but that's condensed for you. But we are going to go through micro right now. Let me share. Okay. Okay. So some of the micro I actually incorporated back into the GI slides because it just made more sense. And so I will go through that in a minute. So I can actually go through that with you guys now because it's the hepatitis stuff, and I actually incorporated a lot of it in here for you guys. The first thing that is incorporated. So this is a kind of micro and path right here. It goes a little more in depth in path, but I wanted to touch on this. This is easy points if you get it. Easy points if you spend 2 to 3 minutes, 5 minutes on the slide figuring out which is which so you can identify it. You'll probably get 1 or 2 questions on this, but again, easy points if you go over it. So esophagitis, just inflammation of the esophagus. Infectious esophagitis, again, any infectious agent. So you have Candida, and this is going to cause a white pseudomembrane. So the way you're going to recognize this in your patient is a white pseudomembrane, and it's going to bleed when it's scraped. This is very much associated with HIV patients because immunocompromised. So something that they get is thrush if their CD4 counts are a little low. So this is actually quite common in that, but that's what it is. And then how are you going to tell if they're not telling you what it actually is and they're just asking for the risk factor? It's pseudohyphae. So if you get a scraping of it, it bleeds, you look at it under the microscope, you see pseudohyphae Candida. Another one, HSV1, HHV1. The description of these are punched out ulcers. That also means a volcano-like ulcer. So this is a large enveloped double-stranded DNA virus. And then CMV causes linear ulcers. That's very important. That description is linear ulcers. This is an enveloped double-stranded DNA. And then this is towards the distal end of the esophagus. So pay attention to these. Again, easy questions if you're going through that. And you should get that on the exam. Let me see where I incorporated micro again. Oh, H. pylori. This is talked about at length in the micro, but there are a few things that is you can focus in on and get the questions right. So H. pylori is one of the causative agents of gastritis. And so this just inflammation of the lining of the stomach. The presentation is going to be nausea, vomiting, epigastric pain. When you go through all of these abdominal pathologies, they're going to have very similar symptoms. Abdominal pain, nausea, vomiting, diarrhea, we're going to get to in the pure micro. But the biggest thing are going to be those big pertinent positives, for example, in the gallbladder or jaundice. And then if you have labs, and so pay very close attention to it. And so if you have H. pylori that is causing the gastritis, it's a gram-negative motile organism, urease positive. This is big, because this goes into the urea breath test. And so this is a test to define the causative agent of pylori. There are other causative agents. And so, for example, Brady is going to go over the difference between NSAIDs, because in the gastric area, you can have pylori, you can have NSAIDs, and then you go into the duodenum, it's different. And so you need to be able to distinguish between the two, because the treatment is going to be different between the two of those. So you have to know what you're treating before you start that regimen. So H. pylori, gastritis, urease positive, you're going to have the urea breath test very, very commonly in the antral part of the stomach. And so you're going to have that increased acid production that is going to give you the risk of peptic ulcer disease. So gastritis is just the inflammation. You have the ulcers, Brady will talk about that, but then this can also put you at great risk for peptic ulcer disease, which is the big overarching syndrome right here. But this is the big thing. There's a lot of information in your macro slides over that. I condensed it down to the big points that you're probably going to be able to see. It's really just H. pylori, figuring out what the causative agent of the symptoms are. So that's the big point there. A lot of other stuff was pretty like one-liners, and so I won't go over that, but I am going to go over, oh, here's another big one. I just clicked on it. Go me. Infectious enterocolitis. So you have a bunch of different causes of infectious enterocolitis, and we'll go over a few of them. I'll actually go over the intro to it now. In the pure micro stuff, we do go over this one by one, but I will do the overview now so you can get kind of the umbrella and then get into the nitty gritty. Of course, abdominal stuff, you're going to have very common symptoms between all of them: abdominal pain, diarrhea, urgency. So amoebic, we're going to talk about entamoeba histolytica, past fecal oral. It's going to have this classic flask-shaped ulcer, so that's going to be a buzzword for you there. It's going to cause a dysentery syndrome, which is I think 10 to 12 watery stools per day. So that's that definition of dysentery. But again, we're going to talk about that in the pure micro slides. How do you diagnose trophozoites containing red blood cells? We're also going to talk about typhoid and enteric fever. This is salmonella based. The big thing, highlight this, star this. This is going to be something that's going to clue you in on, yes, this is salmonella. Faint salmon colored maculopapular rash on the trunk. So whenever you see that, think salmonella. And then depending on what the other factors are, you can clue in on what exactly the species is. Again, we're going to talk about that. I have slides on that. Tuberculosis is a granulomatous infection, inflammation, and then pseudomembranous colitis, which is one I want to focus on right now. This is antibiotic associated. The organism is Clostridium difficile, gram-positive, anaerobic bacillus, and spore-forming motile. So all of those are kind of positive things about the organism. And what I mean by that is, versus non-endospore forming or non-motile. So since these are kind of positive characteristics, I would memorize these in case they want to pull one of those, what is the characteristic of the causative organism question. So just pay attention to that. But look for a patient that just had surgery or an infection. They're going to have just had antibiotics, and they might not throw it in your face. They might have this long venue vignette in like one line or a couple words, like, and they were treated with antibiotics. And now they have this crazy watery diarrhea, but they had antibiotics. Now they have C. diff. That's the big thing. So virulence exotoxins, they have these different exotoxins. One of them is associated with the brush border, and then one of them causes the pseudomembrane. How do you diagnose this? It's the glutamate dehydrogenase antigen assay. There are two other ones, but they're not the best sensitive. Like one of them isn't going to be able to detect during a certain time, and the other, I think it's only sensitive during a certain amount of time. But this glutamate dehydrogenase antigen assay, this is the big one that you are going to be able to say, okay, this is how I'm testing for C. diff right now. And then treatment is a fecal transplant. Yeah, interesting stuff. Okay, and the last thing that is pure micro that I want to go over before we go into those slides are the hepatitis strains. Okay, so hepatitis, this is just inflammation of the liver. This can lead to liver failure, but Brady will talk about that. Acute versus chronic hepatitis can give you both fulminant acute and chronic hepatitis. But so what viral hepatitis does, it's actually cytotoxic killing of the hepatocytes by these viral particles. First Aid has a really nice breakdown. I did put those in this review. So we're gonna go over what I wrote down from the notes, and then we are gonna go look through what First Aid has, because I think it breaks it down really well to be able to see it. So the thing with hepatitis, there aren't as many questions as you think there are going to be with respect to how many slides they put in your notes. The big things, make sure you can pick which type it is, and each strain is going to have a different transmission. So HAV, hepatitis A, this is the fecal oral route. This is only acute. This is outbreak. So schools, camps, restaurants, daycare. So overcrowding areas. You have somebody that goes away to camp. You have somebody, a kid that was in daycare, and now they have these hepatitis syndromes. It's likely HAV. Again, single strand positive sense RNA. You do probably need to know the family name. But that's going to clue you in on, okay, HAV. And then acute infection, anti-HAV IgM, which makes sense. IgM is the first antibody that's made before you get the class switching. And then once you have had the infection or you're vaccinated against hepatitis, then you will have the anti-HAV IgG once it starts class switching. We will go over the serology in a sec. And then HEV, again, single stranded positive sense RNA. I don't remember if I organized this purposefully, but it makes sense to me right now. So I put the specific ones, only acute in the same area. I don't know if I did that on purpose or if it was actually organized like that in the notes, but it's there for you. So HEV is going to be the immunocompromised people. This is undercooked seafood. So this is, again, fecal oral consumption of something. The big thing about this, it's very bad if you are pregnant. There is a high mortality for women who obtain HEV, hepatitis E, if you are pregnant. So that's a big component of HEV. HCV, hepatitis C, most people have heard about this. Single strand RNA. This is commonly with blood transfusion. So you're going to see this in history of IV drug abuse, contaminated needles. That is a big buzz in the vignette. If you see someone with history of IV drug abuse, and then HIV, because you're immunocompromised, you're going to have a higher likelihood of contracting this virus. So something unique about this one, you are going to have fatty liver changes because it's associated with high LDL, VLDL. So those two go together. So this is going to give you a chronic disease, whereas remember HAV and HEV were only acute. So this is the first one that we've talked about right now that is going to cause a chronic disease, hepatitis C. And then chronic hepatitis C, you do have a high risk of hepatocellular carcinoma. HBV is an enveloped, partially stranded, double-stranded DNA. This is a break from the other three. The other three were single-stranded positive sense RNA. So this is our first enveloped, partially double-stranded DNA virus. So make note of that because it's a deviation from the other ones. Again, this is also a blood transfusion. This is mostly acute, rarely chronic, but it's nice to know that it can cause a chronic disease. Again, risk of hepatocellular carcinoma. A big thing about this is you will be able to see ground glass hepatocytes on a biopsy. So you will be able to tell there is a characteristic finding when you do the biopsy. So highlight that. If they say that in the vignette, you can clue in on the cause, because remember, this is also blood transmission as well as hepatitis C. So that can kind of distinguish between the two in the histology. If you have a chronic persistent disease, these are some of the complications. You can have a extra hepatic disease, polyarteritis nodosum, glomerulonephritis. So these are kind of tying it back to other systems. I would pay attention to that because all of these syndromes, the diseases that have multiple system involvement, that's really important to know because you have to look elsewhere other than just the system you're in. So highlight that, just make sure that you understand that this can cause extra hepatic disease. And then if you have a chronic active disease, of course, you can end up with cirrhosis, high likelihood of hepatic cellular carcinoma. We already talked about that. And then another thing to know about this, it's not directly cytopathic. You actually get an immune response with this. So CD8 cells against the epitopes on the core antigen and the envelope. So you're actually killing the infected cells versus the, it's not. And then just a little blurb on HDV. So this is single-stranded negative sense RNA. Again, this is a deviation. The first three were positive sense. This is the negative sense. This is co-infection with HBV. It cannot really exist without HDV, hepatitis D. And so this is a big thing with hepatitis D and B. Now, if you look in first aid, I put this here because it just maps it out so well. So peruse this. I'm not going to go through this with you, but focus in on how you can tell the difference between the two in a clinical vignette. A lot of the time it's going to talk about that transmission. So highlight the transmission. That's going to be a big clue in the vignette. And then you can say, okay, I know what it is now. Then now I can answer any question that they're asking me about this. So yeah, and then this is actually really big. I didn't put the entire thing here. There's like a whole page. It talks about the window period. It talks about the definitions of these things. So go look at it in first aid, but I just wanted to put this in here. This is really important. You will have a couple questions on this. It was really hard when I was learning it, but it got a lot easier over time. So know essentially all of these, quite honestly. When you have an acute infection, what are you going to see on serology? What are you going to see in the window period? There's only one. And so just memorize that. In the window period, you're going to see this. And then immunized versus recovery. So if you are given the serology, can you say, or I'll flip that. If they tell you the condition of the patient, can you tell them what you would likely see in the serology? So that's a big thing. First aid has it lined out very nicely for you guys. And so I would highly recommend going in and looking at both of those pages for hepatitis in the microbiology section of first aid. Okay, so that is it for the micro that I incorporated into the path slides. So now we're going to look at the micro slides that I did for you guys. Again, you guys know I condensed this down. A lot of this stuff is very similar to one another. So what I'm going to focus on is telling you the differences between some of them and how you can differentiate. Okay, so first off, food poisoning. So this isn't necessarily the bacteria that's going in and wreaking havoc. This is preformed toxins or chemicals that are wreaking havoc. So the first one, Clostridium botulinum, again, it sucks. You got to know the characteristics of the causative organism. So gram-positive, motile rub, anaerobe, spore forming. Like I said before, these are all kind of positive characteristics versus a negative I'm making that term up right now, negative characteristic of non-motile, non-spore forming. So I would know these. So you're going to get it from canned low acidic food, improperly canned food. This is one of those things that you always associate, you have those symptoms after eating improperly canned food. This is huge. Highlight this, star this. It's very important. Honey is a risk factor. You cannot give honey to infants below a certain age because you can have infant botulism. And so that is very important. Highlight that, star that. I'm pretty sure, I don't know if it was an IMCQ or if it was on the exam, but that is something you need to know because you cannot give honey at all, period, to an infant below a certain age. Now, what does it do? Again, very high yield, very important that you know the pathogenesis of this. It's a neurotoxin binding the presynaptic membrane, and it's going to decrease acetylcholine release. So you are not going to get those vesicles that are going to attach to the NMJ, release into the synaptic space. Just, you don't have the acetylcholine release, so you don't have that propagation of the action potential at the postsynaptic. Postsynaptic ganglion. And then how do you look for the toxin? You do an ELISA. And then staphylococcal. These are from the dinoflagellates, commonly reef fish, so barracuda. And then ciguatoxin, this is going to activate voltage dependent sodium channels. And so some things that you can see, the perioral paresthesia, so tingling around the mouth, metallic taste in mouth, bradycardia, heart, that's supposed to say heart, I apologize, and hypotension. Scombroid or histamine poisoning. So this is consumption of improperly stored recreational fish catches. This should be pretty easy to spot in a vignette because this is, if you're gonna have cutaneous flushing, rash, anything that's associated with something that looks like an allergic reaction. And then the fish flesh is going to have a peppery metallic taste to it. So that's histamine poisoning. Now we're getting into the good stuff, diarrhea. So this is just an intro. So what we're going to focus on is non-inflammatory and inflammatory diarrhea right now. So the acute. So the big things for you, non-inflammatory versus inflammatory, it's essentially narrowing it down and helping you. So non-inflammatory is going to be secretory watery diarrhea. This is not bloody diarrhea. This is going to be in the small intestine. You're going to have more sudden onset and no fever. So this is pretty much just watery diarrhea, getting rid of fluid. That's it. Now, if you have an inflammatory diarrhea, you will see fever. You will see mucosal, musical damage. Oh my God. Sometimes my fingers go into like muscle memory and just type weird stuff. Mucosal damage, and then still with granulocytes, so leukocytes, and then mostly large intestine. And these are going to be your invasive bacteria, which makes sense because if you invade the mucosal lining, you're going to get an inflammatory response. And that's why we're seeing these different symptoms. And then just more definitions, persistent and chronic. Those are the time courses. Now, non-inflammatory E. coli, we're going to start with that. E. coli, I thought about putting all of the E. coli strains together, but I was like, no, I'm just going to separate it non-inflammatory versus inflammatory. So just know that E. coli does cause both types of diarrhea depending on the strain. Now, E. coli, all of them, gram-negative, bacilli rod, facultative anaerobe, CAP positive, oxidase negative. For each of these strains, zero in on something that's going to tell you what it is. So ETEC and enterotoxigenic, traveler's diarrhea, done. If you know it's traveler's diarrhea, then you know it's ETEC, done. So you need to make that as you need to make that connection between the vignette and the actual strain so that you can kind of get it quickly. You understand. So contaminated food, toxins stimulate the lining. God, there's so many typos in this, sorry, of intestine. So you're secreting excessive fluid. That's why you're getting the watery diarrhea. colonization via, I forgot what that stands for, but it's one of its virulence factors. And then you have enterotoxins. So LT activates adenylate cyclase, increasing cyclic AMP, and then ST guanylate cyclase. So those are its virulence factors. You know they love virulence in factors. Now, contrast to that, EPC, enteropathogenic infantile diarrhea. So this is non-inflammatory, watery, infantile diarrhea. It has none of those virulence factors. What you will see, highlight this is very important because this is something that is characteristic. You're going to have the effacement of the microvilli. Why do we care about that? Because you have loss of surface area, and the microvilli are the thing in the small intestine that really enhances that surface area. So you get maximum absorption. So if you lose that, you don't have it. So again, ETC, travelers, EPC, infantile diarrhea. Vibrio cholera, the big thing here in the vignette, you're going to see rice water stool. That is the characteristic description of the diarrhea here. So if you see that, you automatically know where you are. Again, you need to know the characteristics of the organism. The toxin is a bacteriophage-encoded AB toxin. And then this is one of the augurs you should probably know because it's one of those like special ones. All of the other ones, it's like McConkey. I mean, it's important, but I'm saying this is one of the special ones that they point out to you. So you need to know it. So TCBS augur. Clostridium perfringens. Oh my goodness, you're going to see this in multiple times. So just understand it. Yeah, gram-negative, anaerobe, non-modal. Remember, that's kind of an, I call it a negative symptom. Remember, I'm just kind of making up that term. Spore forming, type A, foodborne infection. There's another one that's different. And so I highlighted this one because it specifically keys in on that. And then you have the CPE. So the it's enterotoxin, and you also have the LT toxin. Oh my God. Okay, Bacillus cereus, again, causative characteristics of the organism. Two types, you have the diarrheal and the emetic form that each, they are caused by different toxins. So understand that. So the LT is diarrheal. And it's also a difference between how you get it. So meat, vegetables, sauces, pastas, or dairy, you're going to ingest the LT enterotoxin, so you're going to get the diarrheal form, versus the emetic form is the SC neurotoxin, and this is food, rice, and pulses. So make sure you can recognize that in the vignette. Norovirus, they love norovirus. Wait, you guys didn't have Harrington? I don't think you did, but she really stressed this. But norovirus, it's extremely, extremely, extremely infectious. Spread very rapidly in big crowded groups. Calciviridate, naked, not naked, icosahedral nucleic capsid, single strand positive sense RNA, winter vomiting disease. But the big thing is cruise ship outbreaks. It doesn't have to be a cruise ship. It doesn't. It's just, that's the example that they use because it's a lot of people in a small confined space, but essentially any crowded communal area. So it doesn't have to be a cruise ship, just that's the example that I like to use. And then you have transient small intestine lesions. It's sparing the large intestine, but this makes sense because we're still in non-inflammatory, because non-inflammatory is small intestine versus inflammatory, which is large intestine. So that makes sense. There's no fecal leukocytes. But the lesions, you can see short microvilli on electron microscope, and then the norovirus will be shed in the feces. Rotavirus, daycare. So you're going to see a kid in daycare. Again, it doesn't have to be daycare, but this is the example they like to use. It's a enclosed space, crowded, lots of people. So just recognize that. Then it's pathogenesis, the replication in the villus epithelium. This causes defects in the fluid and electrolyte regulation. That's my little symbol for electrolyte imbalance. So you can just make a note of that. You guys know I love to shorten everything. But why do we have this? You have production of digestive enzymes from the brush border, and you have this protein that's acting like a toxin, increasing that fluid excretion. This is one of those virulence that they kind of hone in on that's different from everything else. And so I would highlight that. So anytime, again, you guys probably know this, if you have something that's different from everything, it's like, it's special to this, highlight it, star it, you're going to probably have it on your exam. Astrovirus, there's not a whole lot. It's just kind of a mild case of rotavirus, but no, the causative agent, they're probably going to give you rotavirus, but just understand that there's another kind of sub disease from that. And then adenovirus, double-stranded DNA group F infection. Cryptosporidium, so persistent childhood diarrhea. If it's in an adult, chronic diarrhea with AIDS. So you can actually kind of put like a dash between them. I put it on the same line, but it's like two different conditions. So persistent childhood diarrhea or chronic diarrhea and AIDS. So those are two different things. Thing here, a thick walled oocyst. This is the infectious stage that is excreted. And this is also what's going to be diagnostic. So if you find this, you know what it is. And then the special stain that they like to talk about here is the Ziehl-Neelsen staining. And then what is it called? You're going to see the villus blunting, mild inflammation, prolonged diarrhea, and malnutrition. Listeria monocytogenes. The gram-positive, all that stuff, ingestion of raw milk. So essentially refrigerated foods. So because it's in that temperature range, so it can grow really well there. So refrigerated foods. The big risk is pregnancy because it can cause death of the fetus. So highlight that. That's something that is very characteristic of this organism. They can use that in a vignette. Pathogenesis has a few things, a few virulence factors that help its pathogenesis, and I've listed them there. Shigella, we're going to talk about this. No, here it is. Okay, so Enterobacteriaceae characteristics. So non-lactose fermenting. So we're talking about McConkey's auger there. And then H2S negative. Again, daycare, contaminated hands. This is spread very, very easily. So community spread. And then S. soni is the most common. So S. soni is associated with daycare. There are a few more that they point out in your lecture. I did not list them here because this is the one they talk about a lot. By no means like throw that out of your memory. I just wanted to put what I remember as being really high yield. So I'm just saying that they focused on this in the notes. And so I'm putting this here for you to kind of jog your memory. Again, virulence factors. It has a Shiga toxin. We'll talk about the E. coli that has a Shiga toxin as well. And then another virulence, the NAD glycohydrolyzed NAD to shut down metabolism and inducing apoptosis. Okay, more E. coli. So now we're getting into, was that inflammatory? Okay, yeah, Shigella. Okay, we've been inflammatory for a while and I just didn't talk about it. So inflammatory, you know, you have the different symptoms. You're going to have more of the bloody diarrhea. It's going to be the large intestine. And you're going to have the fecal leukocytes. Okay, so more E. coli here. The big one here, of course, most of the information here, you're going to have the Shiga toxin producing one, which is synonymous with HEC and VTEC, so enterohemorrhagic and cytotoxin, but you do have the enteroinvasive enteroaggregative, but we're going to focus on the Shiga toxin one because they really like this one. So you have the toxins there. So the STX1 is similar to Shiga. So O1 E. coli 0157H7 is the hemolytic uremic syndrome. They love this specific, what's the serotype? No, it's not serotype. Okay, whatever. They love it because it causes a bloody diarrhea. So if you see somebody that all of a sudden presents with bloody diarrhea, and this is one of the answer choices, it might be that. They carry it through term 4, term 5. It's a big one. They love it. Cattle and sheep, that's something that if you see that in the vignette or they ask about what's a possible why this person got it. So maybe a farmer or something, like what, how did this person likely get it? Cattle, sheep, something on in the answer choices. But this can lead to life-threatening conditions. This is a big one. So hemorrhagic colitis, hemolytic uremic syndrome, I already talked about that. It's associated with 0157H7. So kids with microangiopathic hemolytic anemia, thrombocytopenia, acute renal failure. So this is big. This is very dangerous. You don't want this. And then thrombocytopenic, thrombotic thrombocytopenic purpura. So you have hemolytic uremic syndrome and fever and a neuropresentation. So how are you going to figure this out? So one characteristic, it is, you will have red, pink colonies of McConkey, and then you will see schistocytes on a blood smear. Come on. There we go. Okay, salmonella, gram-negative, facultative, modal, non-lactose fermenting, non-lactose, that's pertaining to McConkeys. So again, I talked about this before, patient presenting with self-limiting diarrhea, that's one of the characteristics, because this does resolve on its own. If it's not an extensive disease, it can just resolve. And then again, like I said at the very beginning, a maculopapular rash, it's rose colored, salmon colored on the trunk. Highlight this. I underlined it in my path slides, but this is very characteristic. You can clue in on salmonella. Labs can show anemia, leukopenia, no eosinophils, something that it said multiple times. And so I pointed it out for you guys in the notes. There is a history of SCD, sickle cell disease. Now there are multiple causes to this. So you have typhoidal, so typhi, paratyphi. This is fecal oral spread. So this is causing an enteric typhoid fever. This is the more systemic side of it. So you get fever, headache, weakness, all of those symptoms. Now, when you're talking about the gastroenteritis, that's when you're talking about non-typhoidal, the typhimurium enterid, and I can't say that. So this is what you think about when you think poultry, dairy, you know, undercooked chicken or raw chicken. This is what you're thinking about when you're thinking about that diarrhea, that GI disease. You're talking about non-typhoidal salmonella. So poultry, dairy, again, self-limiting gastroenteritis. And then a septicemia can be caused by Salmonella coalescens, and I can't say it. But these are three kind of presentations all within Salmonella, but different species within Salmonella are going to cause this. But since we're in the GI system, we're going to focus on the non-typhoidal because that's just where we are. So I would highlight that, but I put it all on here. And then Campylobacter jejuni, you will see this all throughout term 5. So remember this. This is associated with Guillain-Barré syndrome. So again, gram-negative, spiral rods, motile, microaerophile, this characteristic. Sheep's, pigs, pet stores. And then you are going to see a Guillain-Barré-like syndrome. And so you have the antibodies against LPS cross-reacting with GM1 gangliosides in the myelin sheath. So for your purposes in term 4, you need to know the nitty-gritty. You need to know what's actually going on with, so the GM1 gangliosides, myelin sheath, I would know that. When you get to term 5, make sure you do connect the two, Campylobacter jejuni and Guillain-Barré syndrome. That's going to keep coming up, keep coming up, keep coming up. Then Yersinia species, specifically I'm not doing well today, guys. Enterocolitica, I might have spelled that wrong, I don't know. But Enterobacteriaceae, gram-neg, all of that fun stuff. So farmers and vets, again, that's going to be something anytime you see a epidemiology, some there's another word I'm trying to, whatever. Highlight it. because those can clue you in on what it is. There are so many times where I knew what organism it was simply because of, you know, it would say like farm or sheep or something like that. So highlight that. Chromosomal ST enterotoxins, self-limiting enterocolitis, abdominal pain, diarrhea, fever, that's pretty common. Stool culture, pinpoint colonies on McConkey. I would highlight pinpoint colonies because that can help you in the vignette. Something that's really, really big, something that's specific to this particular organism is the pseudoappendicitis. That's really big. Highlight it, star it, underline it, whatever you want to do. But this is something that's very specific to the Yersinia species. So highlight it. You're probably going to test on it because it's one of its special things. Non-cholera vibrios, parahemolyticus, so seafood, raw fish, and then vulnificus, you're talking about kind of the Gulf of Mexico. Yes, that is important. So Japan versus Gulf of Mexico, because it can clue you in on what you're kind of looking at there. So it can cause an acute gastroenteritis. You have necrotizing wounds and you have invasive sepsis. So you have different presentations. Again, we're really talking about GI, so focus in on acute gastroenteritis, so the raw or undercooked shellfish, but just understand that it can cause all of these different presentations. Okay, now we're getting into the parasites. This is where it gets really mundane because it feels like it's saying the same thing over and over and over and over again. So I'm going to try as best as I can to point out the things that are specific to each one of these. I was making these slides. I was like, I don't know how to tell these apart, but I'm going to do my best to clue in on what I remember you need to focus on and the differences between them. So fascioliasis, fasciola hepatica, this is a liver fluke, sheep liver fluke. Again, anytime they tell you the specific vector or anything, know that because it can help you identify what it is. So it does have, it's a trematode. It does have an acute phase and a chronic phase. The thing that sticks out to me here, and I would highlight this, are the different symptoms. So the acute phase, okay, fever, right upper quadrant pain, hepatomegaly, okay, but the cough, shortness of breath, and chest pain. So you're getting those symptoms that are a deviation from the abdominal symptoms that we've been talking about. So this is something different from the other ones. I would highlight it because it can clue you in on, oh, this might be something other than this that, you know, is limited to the GI system. So highlight those. This is something different. The chronic phase, you're thinking more gallbladder at this time. So biliary colic, intolerance to fatty foods, epigastric pain, all of these things. How are you going to diagnose? You're going to see the ova in the stool. Clonarchiasis, again, liver fluke, raw pickled smoked fish. You're going to see kind of the same symptoms, chronic infection. You can have adenocarcinoma of the bile duct. This is another deviation, so I would highlight that. So if you see this, this might be a complication that you can get down the line. And then if you get invasion of the gallbladder, you can have cholecystitis, cholelithiasis, impaired liver function, and liver abscess. Those last two lines I would highlight because that is a big thing for this. But the adenocarcinoma, definitely I would key in on, okay, this is something different than all of the other parasites that we're talking about. So this might be something that they focus on. But again, you have those general common GI symptoms. Then amoebiasis and Entamoeba histolytica, it's a protozoa, trichozylites in stool. This, remember I was talking about the gastroenteritis in the path slide. So you have dysentery, which again is 10 to 12 bloody mucosal stools per day. That's just the definition of dysentery. There are a couple things I believe that can cause dysentery, but that's the definition of dysentery. And then a big thing here, clue in, I underlined it, the liver abscesses that you can see on ultrasound, CT, or MRI. If you take an aspirate, if you try to culture that, you are going to see a reddish brown anchovy sauce. But it also, you can highlight this, I did say it above in the past slides, a flask-shaped lesion. That's something that you can see in the intestines to clue you in on, okay, this is amoebiasis. Okay, the next few, like I said, it kind of touches on it. So Bacillium coli, the reservoirs, pig zoos, Giardia intestinalis, foul smelling, greasy diarrhea, steatorrhea. So you have lactose intolerance, so you're getting that malabsorption. I would highlight this. Again, this is kind of a deviation. Cysts and trophozoites in stool, and then you have a bunch of different tests that you can use for that. So I'd highlight that as well. These ones that I just kind of like 1 or 2 liners, I don't remember them being the biggest high yield. Again, I'm really just going off of what I remember, by no means like push that from your memory, but I just really want to focus in on what is high yield for you guys so you can get the most points last minute. Cyclospora, no, I'm not going to try that one. I'm not going to read this to you. I am going to make a point though. The ones that have the parentheses and like pinworm, whipworm, memorize that name, because I was very surprised on the exam. It very often had the layman term for it versus Enterobius vermicularis. Know both of those. It'll get you a couple points. You're not going to kick yourself in the butt like I did on a couple of those, because I memorized the genus, species, and not the layman's term. So learn from my mistakes. So this is this is a big one for Enterobius vermicularis, the perianal perineal pruritus. This is the one where the eggs come out at night. And so you can do the sellotape or scotch tape or whatever for the eggs, and you can catch it, and that can tell you what it is. So that's high yield. Highlight that. Trichoris, trickier, whipworm, the nematode. So this is also characteristic. So barrel shaped bioperculate, bipolar eggs. But kids, you can see iron deficiency and then growth retardation, and then you can develop a tricurious dysentery. Remember, that's just a lot of bloody diarrhea. Okay, tapeworm, you can get this from smoked raw pickled fish. You get the general GI symptoms, prolonged infection, megaloblastic anemia, highlight that. That's a deviation. That's something specific to this one. Something also specific to this one, proglottids and eggs in stool. Dwarf tapeworm. That one, I don't remember being huge. Roundworm, this is a big one. A Loeffler syndrome, all that means is a self-limiting pulmonary eosinophilia. So this is going to have pulmonary symptoms. Highlight this one. This is something that if your patient comes in and they have all of the generalized GI symptoms and they have these pulmonary symptoms, it can clue you on it. Oh, this is roundworm. Lumbricoides. There we go. Then this is actually kind of weird, because you can have like a large worm burden and it can actually cause an obstruction in your system. So that weirds me out. I don't know about you, but like a bolus of worms in your GI system, which can cause a lot of issues. You can get dissension, of course, your anorexia, weight loss, and then heavy burden. You can actually get the bacterial peritonitis, can migrate through the bile duct into the liver, into the gallbladder. You can get cholecystitis. So how does it get to the lungs? So you ingest the eggs, which hatch in the small intestine, they get into the blood, and they migrate to the lungs. So I would know the pathway there. Okay, these are the last two: hookworm, ankylosarcoma, duodenal. So both of these are kind of similar. Both of them are going to have skin presentations. And the big thing to note is that because it penetrates the skin, up until this point, all of the ones, I didn't actually write it on the slide, but it's all ingestion of the eggs. Every single one of those, it's ingestion of the eggs, either through contaminated food, contaminated water, and then it has its pathway through the system. These two right here, the hookworm and the threadworm, it's penetration through the skin. So you're going to have a cutaneous presentation there, and then eventually gets to its endpoint. So these two, that's a deviation from normal. I would memorize that being the difference in these two. So the hookworm, erythema, macros, papules, epigastric pain and bleeding. This one has the iron deficiency, protein energy, malnutrition. This is different from the threadworm, so you can highlight that. That's supposed to say abdominal, not ABS. Adult worms, so you can have a chronic abdominal pain, eosinophilia. So again, penetrate the skin, you can get into the circulation, into the lungs. Once it gets into the lungs, it's going to penetrate the alveolar spaces, trachea, and then swallowed, which is how it gets to the small intestine. And then the eggs are shed in the stool. And then you kind of have this round and round we go, because the eggs are shed into the stool, and then you have the pathogenesis there. But the rhabdidiform, okay, there we go, larvae. And then the threadworm, it's kind of the same thing, localized urticarial rashes, pulmonary, you have pulmonary eosinophilia with this one. Diagnosis, the rhabdidiform larvae in stool, they penetrate the skin, but this is big on this one. This is something that can help in your diagnosis. You have inflammatory inflammation, that's what I was supposed to say. Inflammation around the migratory tracts near the surface. I did not do a good job on my typing towards the end of this. I apologize, guys, but inflammation near the migratory tracts near the surface. So cutaneous strongyloid diasis. But that is the GI micro. I hope that helped. But I guess we can take a 5-minute break unless you guys want to just go for it.
Yeah, let's just give them 5 minutes and then we'll get started on the pathology stuff. Y'all could put any questions y'all have in the chat. Thanks, Lindsey. All right, so we'll get started in a second. I wanted to run something by you guys. Lindsey and I actually spoke with, so Dr. Rabi from DES contacted us, and she was interested in us doing a project. So what we're looking at doing is kind of looking at, we want to do a research project on how people actually learn. Okay, so like, especially you guys, what we're going to try to do is like put a survey that might take about 20 minutes up on our pages. We're still in the approval form, but what we actually want to do is kind of streamline the process of, especially for the lower term students, of using outside resources and stuff. Because as it is now, and y'all know this, it's kind of like word of mouth or trial and error, but we want to streamline the process and kind of put together a roadmap. For instance, if you didn't do good in one area, maybe you should try Boards and Beyond, or maybe you should try Anki or something like that. So we're looking at taking a survey of a bunch of different students. It'll all be anonymous. And we want to kind of put together something that would be easy for the school to present and say, this is a systematic way of approaching learning for different areas. So be on the lookout for that in the coming weeks. But we're basically just going to do a pros and cons list of what people use, what people didn't use, and kind of like your learning style, because as you guys know at this point, the faster you can, well, one of the most difficult things about med school is learning how you learn. And the faster you could figure that out, the better you'll do. So we want to try to make it more of a objective approach towards using different resources and how to study. So if y'all do see that in our pages, we would very much appreciate y'all pitching in, because y'all being almost done at this point would have a lot of knowledge on that stuff. So look out for that. Anyway, all right, so let's get to the pathology stuff. Let me share my screen. Okay. All right, so I'm not going to have the chat up. So if you have any questions, just speak out loud. I don't mind. Okay, so as always, all of my notes are posted on my drive. They're highlighted. If you don't know by now, I have like this neurotic way of highlighting things, kind of like my first pass. You could see here, buzzwords or keywords are usually in red, and then something kind of semi-important can be in green, and white is, yellow is kind of less important, or more descriptive analysis. So that was kind of my approach to doing this. It makes it easier for me when I go back before the exam and look at stuff. So that's how I do it. Those are all posted. These notes should be the same as yours. So we'll just go through them. We'll focus on the clinical aspects of things, And again, if you'll have any questions, just let me know. Or if I'm going too fast, just, yeah, we can slow down. All right, so when we look at some of this, these diagnostic or these pathologies here, leuco meaning white plakia, you see these white patches. Anytime you think white, think candidiasis, candida, which is usually some sort of immunosuppressive thing. You can see it in transplant patients. You can see it in HIV patients. So you have to watch out for that. Usually, if your T cell count's below 200, you can see stuff like that. So leukoplakia there. There's also some other ones, oral hairy leukoplakia, but the ones they really talk about is this white patches, which is classically candidiasis. Okay. But you can also see tobacco, chronic friction, or even HPV can lead to this as well. And then oral leukoplakia is classic with EBV, Epstein-Barr virus, which causes mononucleosis. So kind of correlate those together. But again, you usually only see this in immunosuppressed patients, like HIV patients. Okay. Now, the big thing, come across a lot of board questions, and the only diagnostic clue when you base it, whether it's squamous cell carcinoma versus some sort of glandular carcinoma like adenocarcinoma is where it is in the esophagus, okay? So the first half or even the first third, really, we're talking about squamous cell. So anytime they give you something up in the oral cavity or first third of the esophagus, think squamous. Smoking's a big one for this, that would lead to this. And also always with squamous, whenever you see something that says pathologically, anything with keratin pearls, keratin is always related to these squamous cell carcinomas, okay? So that's what you need to know there. Big one here is gonna be the tobacco, the smoking risk, but these are all possibilities here. So again, you'll be at the upper portion of the esophagus. These are those little keratin pearls, okay? That's what you can see here. So there's a classic for squamous cell. And again, you can see this leukoplakia here in the mouth. All right, now y'all learned this at length. Looks like B is the most common one, that those TEFs, those kids, remember they go to feed their first feeding and they get this projectile vomiting. That's because you could see the esophagus here is blind. There's nowhere where the food could go. It's got to come back up. They also get that large gas bubble in the stomach, and that's because when they swallow air, or when they breathe in, they end up swallowing air. So they get that large gas bubble. This obviously has to be corrected. This has to be corrected surgically for them to survive. But remember, this is very different from like pyloric stenosis and stuff. This is the very first feeding, okay? You can see that with other stuff, but they classically in the question say this is first feeding because you can see there's literally nowhere it could go. It's got to come back up, okay? And aspiration pneumonia is a big one here too, obviously, because the food's coming down the trachea, you can get aspiration pneumonia that way. Okay, so these mucosal webs, if I remember, so Plummer-Vinson syndrome has this triad. Yeah, iron deficiency anemia, I think glossitis and chelosis kind of go together in that triad, and then you get these mucosal webs, okay? So Plummer-Vinson syndrome is one of those things you kind of need to commit to memory, and then it does have an increased risk of squamous cell carcinoma, okay? So think the upper aspect of the esophagus, okay? So remember that as a triad, not super important, but I think for a step, that might be a good thing to keep in mind. And it's associated with gastroesophageal or GERD, right? Gastroesophageal reflux. So that's a good one to know. And these webs are just rings or just constriction points, okay? So covered by the squamous epithelium. You can actually see this at the lower part as well. So they're just constriction points. Obviously, it's hard to have peristalsis when you have this fibrosis or these constriction points, okay? So these are these scatchstick rings, probably butchered that, but just these esophageal rings as well. But I think the main thing here is to remember this Plummer-Vinson syndrome and that little triad that kind of goes with it, okay? If it helps you to remember, iron deficiency anemia would lead to, you also have this B vitamin type deficiency symptoms with this glossitis and chelosis similarly, okay? So that's kind of how I put those together in my brain. All right, and achalasia, we always talk about achalasia when we talk about this. You don't have this innervation to the lower esophageal plexus. This is a failure of neural crest cells to migrate. one of those things that happens similar to Hirschsprung's disease. So you have absence of these ganglionic cells. So you end up getting that bird's beak appearance, right? So they may have a picture of it or not. Y'all are probably familiar with the picture. It kind of like as you get down, you get all this food that comes in and you get there, and then there's the stomach right here. So this area here is that part that has this loss of this lower esophageal sphincter, these ganglion cells. So all the food builds up here, and you don't get peristalsis in this region here. So yeah, obviously it ends up in with some GERD and stuff like that. Some of the problems, Trypanosoma cruzi is a common thing. Chagas disease, remember that's South America. That's where you have to worry about stuff like that. So that's a big one there. But usually this is one of the big ones. They'll give you one of those barium swallows, right? So you see it and it'll show you that bird's beak appearance. So that's what you're looking for. That's achalasia. Keep in mind, if they ask, it's loss of the neural cells, these ganglion cells there, okay? All right, big thing here, the same principle is going on here. It's this, this retching problem. Typically the retching that's causing these Mallory-Weiss tears is caused by alcohol intoxication. So you get failure of relaxation, but again, it's this retching, but they do correlate it with the alcohol intoxication. But you end up getting mucosal tears. I'm pretty sure they specifically say longitudinal. There they are. There it is. Longitudinal mucosal tears. So if you see these tears, you think in Mallory-Weiss tears, think alcohol intoxication. If you get these tears, you're going to be throwing up blood as well. So keep that in mind. And yeah, I think, and then Borhave syndrome, transmural, this is going to be worse, right? So transmural means all the way through the wall. If it's transmural, that you end up getting air in, where is it? Leakage of air into the severe mediastinum. So you get air into the mediastinum, and that's because you have a transmural tear all the way through the wall. So you can keep these together as they're both tears. Mallory-Weiss is due to alcohol, but Borhave is going to be much worse. You're going to get air into the mediastinum, so that needs to be corrected. Okay, wait, sorry. Why don't you go back? Whoops. Give me 1 second. All right. All right, so Mallory-Weiss, you're thinking blood coming up, Borhave syndrome, air there, and Borhave again is going to be to this severe retching. Okay. You can see these longitudinal tears here. You see that blood that's forming. It's going to lead to hepatimesis, right? Hepatimesis. I think I'm saying that correctly. Yeah, this vomiting of blood. Okay, it's in the lower aspect near the gastroesophageal junction. And again, Mallory-Weiss is longitudinal tears. They like to put that in either in the stem or in the question. All right, so reflux, again, we're going to be in the lower area. You've learned about Barrett's esophagus a million times now, where you get that metaplasia, where you get that gastric lining or that gastric, those gastric cells, those the columnar cells that come up where, into the esophagus to help to compensate for that reflux of acid, okay? So because of that, it can lead to adenocarcinoma or glandular carcinoma of the esophagus. Okay, remember metaplasia is reversible. You fix the GERD, then that metaplasia will go back to a squamous form, which is what it's supposed to be in the esophagus, okay? So keep all that in mind. Make sure you know it is called columnar metaplasia. So you define it by the new cell type. Okay, so the squamous turns to columnar, but you would define that as columnar metaplasia. You define it by the new cell that's formed. To correct it, you need to correct the acid that's developing in the esophagus. All right, let's see, nothing crazy here. All right, and it says here, yes, of course, you can get cancer, specifically adenocarcinoma, adeno meaning glandular, okay? So that's what you're gonna get. Right, so look, metaplastic columnar cells. You can even see goblet cells up there, okay? So you're trying to compensate for all that acid that's coming up into the esophagus. But y'all know that by now. Here's a nice picture of it. You could see this would be that LES. You could see the rugae in the stomach, and you're looking at the esophagus up here. So all of this is metaplasia. It's changing over there, and you can see this. I don't know what kind of stain this is, but you could kind of see the metaplasia there. Yeah, and look, you could even see these goblet cells that are forming there. Okay, so keep that in mind. All these pictures are fair game just because you should definitely know Barrett's esophagus by now. Right, again, adenocarcinoma is the long-term complication there of GERD. Then esophageal varices, right? These are those dilated, tortuous veins that form. A lot of times this is due to liver failure. You get that portal hypertension. You get those pathological anastomoses, caput medusa, but specifically here, we're talking about the esophageal varices. So if any of these rupture into the lumen, you're going to get hepatemesis. I feel like I'm saying that wrong, hepatemesis, right? So vomiting up of blood. And yeah, so anything cirrhosis, hepatocellular carcinoma, anything that's blocking that blood and backing it up into the portal vein can lead to these anastomoses and these varices that form. Okay, yeah. See, okay, and we kind of talked about this. Squamous cell is the upper area, adenocarcinoma is going to be the lower area. So make sure you're able to differentiate those. Yeah, we kind of talked about this. Alcohol could do it. The big one we talk about is, that smoking history, alcohol, tobacco. Achalasia, you get that, you can't fully digest food or fully, get food from the esophagus to the stomach. And we talked about Plummer-Benson syndrome too. But by all means, a smoking history is going to be the big one for this squamous cell carcinoma in that upper area. All right. Yeah. Let's see, adenocarcinoma, you're looking at the lower area, so this glandular portion, okay? Can't really appreciate the glands here, but yeah, again, GERD is going to be the big one that they talk about with that metaplasia there. All right, cool. What's next? Stomach. All right. Okay, so pyloric stenosis, right? That's going to lead to problems with digesting. If that stenosis is not atresia, right? Stenosis is narrowing. So you can technically get food down, but you're going to get this backup of fluid. It's going to lead to this non-bilious vomiting. Why is it non-bilious? Because you didn't get to that area of the duodenum to where the bile comes out. Okay, so they'll specifically say non-bilious. You're above that second area of the duodenum here. Okay, so it's common things that can cause it to these trisomies, Turner syndrome, even esophageal atresia. It kind of makes, well, yeah. Well, if it's atresia, you wouldn't think it would go down that far. Anyway, that's what it says, esophageal atresia. But again, you get this hypertrophy of the muscle there. So if it's hypertrophy, it's not going to relax. So, you're going to get this stenosis. So it's going to be hard for food to get from the stomach into the duodenum. Okay, and then you have erosive versus chronic non-erosive gastritis. So erosive, when you think of erosive gastritis, you're thinking about ulcer formations, right? Depending on the depth of the ulcer, can tell you the severity. They like to these things. Cushing's ulcer, the way I remember that is like your head's like a cushion, or like you need to have a cushion. So if you get some sort of trauma to the head, you can get these Cushing's ulcers that form. I can't exactly remember. I think it has something to do with ACTH release or increase. Somebody could correct me if I'm wrong, or some sort of increased intracranial pressure, but it causes, I think it's ACTH, because that'll end up causing, increased acid secretion in the stomach, and that could lead to that. You can also have severe burns, curling ulcers. When you burn paper, it kind of curls up. I don't know if that helps you out, then go for it. But NSAIDs are a big one. You know that already. And that's the big one there. Non-erosive gastritis is more of like, and encompassing the whole stomach, right? But it still is inflammation. It just doesn't necessarily erode into the, depth invasion like these ulcers do. But you can get ulcers from H. pylori, but they're classified here as non-erosive gastritis. So you can also get pernicious anemia. Remember, that is an autoimmune problem where you get antibodies against those. Which cells are those? Somebody help me out. We'll get to it in a second. I forget. Okay. Yeah. What are they? Anyway, it'll come up in a second. All right. So look, you can see these ulcers that form here. So when we have depth invasion into it, so the depth will determine the severity here. So when you have this injury here, like this non-erosive, you just kind of get inflammation here, but it's not diving into the different layers. Okay, right, erosions, ulcers, obviously neutrophils are in that acute phase, this active inflammation of gastritis. You would expect to see that. Okay, and we kind of talked about curling versus Cushing there, so that'll cause acute gastritis. Look at the time frame that we're talking about there. Okay, and then chronic, when you have H. pylori, I mean, unless you start giving antibiotics, you're really not going to correct that on its own. So this could lead to more of a chronic gastritis. So look at this. I put up here in my own notes, this time frame you're looking at acute. This is an acute problem, burns or some sort of head trauma, versus chronic is, over time that you're looking at this autoimmune problem or this chronic invasion of H. pylori. So that will lead to that. And when you think, not that the chronic isn't bad or this non-erosive isn't bad, but when you start getting erosion into the mucosa, I mean, you start getting bleeding into so, you could think of that as more of an acute attack. Okay, yeah, and like I said, neutrophils, this is acute active phase that's going on here. And you can see that when you have this invasion, that's what you would expect to see. All right, and you should know, gram negative. Big thing here is that H. pylori produces urease. Why is that important? Because they use the urea breath test as a diagnostic clue here. They test for the ammonia here, and that's how they can diagnose if it's elevated. That's usually indicative that there's some sort of H. pylori infection going on. Okay, of these, that would be the most important one of these virulence factors to know. So yeah, the problem here is that this urease will help to bring up the pH in the stomach, the ammonia specifically, so that the H. pylori can survive. And in order to counteract that, you start making more acid, and it leads to this imbalance that causes this erosion. Okay, and you could see that increased gastrin locally. Parietal cells, that's what they are, right? So parietal cells produce hydrochloric acid, but they also produce intrinsic factor. And so if you have increased gastrin, so the G cells will make gastrin. The gastrin is going to come from the duodenum and activate these parietal cells. The parietal cells will then secrete acid. So if you have increased gastrin, you're going to get increased parietal cell activation. That means you're going to get increased acid. So you're going to get an increased predominance of peptic ulcers, okay? And you can see this primarily in the antrum. This atrophic gastritis, so you get decreased parietal cell mass, okay? So if you get decreased parietal cells, you're going to get decreased acid production, okay? So this will actually decrease the risk of peptic ulcers. That's because you're just not making acid there. So not super important. I think the main thing here is to know that this pathway, that these G cells will activate parietal cells. Now, not only is it a problem with the acid, but if you're not making intrinsic factor, then you can't properly absorb B12. Remember, B12, it binds intrinsic factor that's made by these parietal cells. It's then brought down through this small intestine to the ileum, where the B12 is absorbed. So this is a common cause of B12 deficiency, which leads to megaloblastic anemia, hypersegmented neutrophils, and remember, you get neurologic signs as well. That's the diagnostic clue to know B12 versus folate deficiency, okay? They both make this megaloblastic anemia, but if the patient has some sort of peripheral neuropathy or nerve issue, that's indicative that's a B12 deficiency. So one of the things here is this autoimmune gastritis against these parietal cells, they may need to be on B12 supplements until this is corrected. Okay, all right. And you can see here, this is what we're talking about. It's parietal cells, intrinsic factor, that's going to be made. So, right, absence of chloride or absence of this acid, that's what's going to be produced or not produced. This acid is not going to be produced because you don't have the parietal cells because you're attacking it. You have autoantibodies against it. And again, you're also going to get this pernicious anemia because you're not making intrinsic factor. So this is a common thing. This is a common thing that's tested. You need to understand this whole process here. Okay. All right. Now, if we were differentiating these H. pylori versus autoimmune, you could do it by the area here, the antrum versus the body. And then you could see, I think the main thing to know is H. pylori can lead to these malt lymphomas, okay, versus autoimmune can lead to carcinoma. They could both primarily are going to deal with adenocarcinomas, but I think specifically H. pylori is related to this lymphoid lymphoma, okay, so this malt lymphoma, mucosal associated lymphatic tissue, okay, so that's an important thing to know for H. pylori. And also, as with any autoimmune problem, rheumatoid arthritis or whatever, if you have one, you commonly have multiple, okay? So you get these autoimmune problems, they coexist with other autoimmune problems, okay? And then we can get into peptic ulcers. All right, so what's the problem? Why do NSAIDs cause peptic ulcers, right? So remember, prostaglandins have, they help to protect that mucosal lining. So then one of the main things that NSAIDs do is decrease prostaglandins. That'll decrease fevers, decrease inflammation and stuff, but it also decreases the protection of that mucosal lining. So NSAIDs in and of themselves will cause this. They usually put in the stem. It's pretty straightforward. They say some person hurt their knee and they've been taking ibuprofen like 6 times a day, right? And then they have this nuance that bleeding, they're coughing or throwing up blood or whatever, or getting, GI pain. So that's usually due to NSAIDs. Again, more of a long-term problem is this H. pylori infection. But again, you can get this chronic gastritis, but look, you can see here that these H. pylori infections can lead to ulcers, okay? So don't get that confused. And of course, tobacco, cigarette smoking can do that too, okay? Super important. Zollinger-Ellison syndrome is a gastrinoma. I think maybe in term 5, we got into it in a little bit more detail, but just know that it usually causes a ton of gastrin, right? A ton of gastrin, or which increases the amount of acid. So you're going to get peptic ulcer disease just because a lot of acid there. Oh, here's a big thing here is that because it's so much acid, and it's coming from the pancreas here. That's where it starts. I believe it's the head of the pancreas. Because you can get G cells in the duodenum and in the pancreas, but usually this comes from the pancreas. But what you'll see is you also get ulcerations in the duodenum and the jejunum. That's not common. Like if you had an NSAID or H. pylori problem, it's usually restricted to the stomach and the first part of the duodenum. But you can see here that this acid that's forming goes all the way to the jejunum. Okay, so if they ever tell you see, peptic ulcers or ulcers in general that could travel all the way through the duodenum to the jejunum, think Zollinger-Ellison syndrome. Okay. All right. And you can see the different areas here, and know that these ulcers can erode all the way through the mucosa, right? You can get bleeding into the lesser sac, if y'all remember from term 1 or whenever we talked about that. Even if it's bleeding into the duodenal bulb, that posterior aspect of the duodenal bulb, remember that gastroduodenal artery travels right behind there, so you can get injury there as well. So just keep that in mind. All right, again, we've highlighted this a couple of times. This acute active infection, you're looking for neutrophils there, okay? That's constant, right? You're not doing a lot of repair. There's not a lot of macrophages at this point. I mean, eventually you get granulation and fibrosis, but this is a constant insult, okay? This is a constant problem that's forming, so you're gonna continuously get these neutrophils there. All right, and another problem if the ulcer, erodes all the way through the mucosa, you can get pneumoperitoneum. What does that mean? Air in the peritoneum. So it usually rises, so you'll see like a little air layer on CT scan above the liver, especially, and sometimes above the stomach. We may have a picture of it, or maybe not. But you could look that up. But you see like a little air thing. That just means that somehow air, there was some sort of ulceration that went through the mucosa, air got out, and so you get air in the peritoneum. It just, it's not going to go away very quickly. I guess eventually it has to be absorbed somehow. Yeah. All right, and we kind of talked about this. So the NSAIDs are going to, inhibit cyclooxygenase, which long-term or, down the stream is going to decrease your amount of prostaglandins. So it's going to be hard to protect the mucosal lining. Remember, prostaglandins also promote vasodilation. Okay, so if you don't have them there, you're going to vasoconstrict the area, so you're not going to get a lot of repair in that area as well. Okay, bicarb secretion as well. Yeah. All right, and then you can get into the adenocarcinomas. Remember, this is glandular carcinomas. Okay, so whenever you're confused and thinking about what's going on, what kind of cancers are most common, just think about the predominant cell type there, right? So there's a lot of glands in there. The gastric lining is made up primarily of glands, so you're going to have a lot of adenocarcinoma in that area. So you can see that most common, that would make sense there. Gastritic, peptic ulcer disease, right? You would expect all this as well. I'm not sure if they really talked about the smoked foods, but it is a thing there as well, these adenocarcinomas. I don't think they went too detailed, maybe just being able to differentiate these. H. pylori would be more of an intestinal problem. Remember, a lot of times you get those H. pylori problems, like those peptic ulcers in that first part of the duodenum. Okay, there's a little bit more bicarb, the pH is a little bit more elevated. So you can get intestinal problems there. This is a big one, not any, well, just because they like to test on this E. cadherin with diffuse adenocarcinoma. I remember this coming up specifically. I think that has to do with like desmosomes or one of the adherent, I forget. But just remember, E. cadherin has to do with this diffuse adenocarcinoma, okay? Yeah, you see this is very much glandular, and a peptic ulcer looks here, can lead into this adenocarcinoma, or it already has apparently. All right, and then this is another one, Limitus plastica, kind of has this plastic appearance too. You can see these signet ring cells, right? You can see because they're kind of pale in the center, and the nucleus is pushed to the side, kind of looks like a ring, okay? So this is classic for this diffuse gastric adenocarcinoma. So if we go back, specifically this E. cadherin problem, okay, germline mutation, whereas this intestinal is an insult primarily due to metaplasia or H. pylori. This diffuse is familial, okay? So you will see this in families. So keep that separate. You should be fine there. Signet rings on the diffuse side, this limitus plasticus as well. Okay. All right. Another big one that keeps coming up, these different these different metastases. Okay, so you can get what you can see with these adenocarcinomas is you can get a Krukenberg tumor those form in the ovaries. It can spread to Virchow's node, which is a common drainage point for lymph. You can also get the Sister Mary Joseph nodule. It's periumbilical. Blummer's shelf, I don't remember that one coming up, but it goes down the pouch of Douglas. And acanthosis nigrans, which is typically classically known, is due to insulin resistance. So anyway, if you see these, primarily these first three, you should think of adenocarcinomas, okay? And then you can get these stromal tumors. I don't know that this really came up. Intestinal cells of Cahill. Yeah, I don't remember this being super important. Tyrosine kinase. So anytime you have a tyrosine kinase, probably KIT, imatinib is a treatment. It's a tyrosine kinase inhibitor. Okay. All right. Cool. All right. right? Meckel's diverticulum, y'all learned this a few times now, rule of twos, 2% of population, males, it's 2 inches long, 2 feet from the ileocecal valve. But why is it not here? The most important, oh, here it is. 2 types of ectopic tissue. This is the question they like to ask. You need to know that this ectopic tissue is not supposed to be there. You'll find gastric and pancreatic tissue. Okay, they call this heteroptia. Don't know that that's important, but just knowing that Meckel's diverticulum, they could ask you, this is also a rule of twos, 2 types of ectopic tissue, specifically gastric and pancreatic. I think this came up on one of our cumulative exams this term as well. Then you get into these malabsorption syndromes, steatorrhea, fatty stools, malabsorption. If you're not absorbing fat, huge problem, right? That could lead to fatty stools, foul smelling, they float. So you can see that greasy, difficult to flush, clay colored, because they don't, typically if you're not absorbing fat, you're not getting, a lot of times it has to do with bilirubin, right? So the bilirubin gives color to the stools, okay? So pancreatic insufficiency, like in cystic fibrosis, stuff like that. Celiac disease, you have the villi, the blunting of the villi as well, so you don't get absorption, and Crohn's disease is a big one as well. All right, so what are the consequences here? Anemia, mucositis, right? Bleeding, so vitamin K deficiency here. It can even lead to osteopenia and tetany due to these decreased absorption of these vitamins as well. So just a whole bunch of different things that can happen here. B12 is a big one here as well, or even vitamin A. All right, so celiac disease, classically gluten, they have a sensitivity to gluten, so they can't have that in their food. I think this actually came up. It has to do with these HLAs, specifically to a DQ2 and 8. So that's different from some of the other things. I think they come up in this lecture too, but celiac is 2 and 8. Okay, so they need to get this gluten out of their food because they have a sensitivity to it. Okay, you can see that here, very important. You need to know these. They'll ask you any of these right here, and these are indicative that diagnostic for celiac disease. Okay, one of the big things here, it can increase your risk for B-cell lymphomas as well, okay? Classically, they'll say this all the time. I don't know if it's the only, it's probably, well, it's not, because lactose intolerance will cause this villus blunting as well. But whenever I see villus blunting, like the first thing that comes to mind is celiac disease, okay? And again, in red here, I think this is the main one. They use this tissue transglutaminase antibodies because that's the enzyme that really does all the work. But this gliadin and anti-endomesial antibodies. Okay, so any of these, fair game for the test. You should be thinking celiac disease. Now, tropical sprue, typically you see this in South America. You can get this here. It will respond to antibiotics, but T. Whippley is, oh, sorry, no. What is tropical sprue? Wait. Doesn't a specific, so somebody can say.
They didn't give us a cause for it. They just said it responds to antibiotics.
Okay. For some reason, I think I remember there being a specific, I could be wrong. Okay, that's fine. Meaning it's acquired, right? That's fine. Whatever it says here, just know that South America, they tell you that they recently traveled. Response to antibiotics, difficult to differentiate from celiac, but remember, celiac is a familial or inherited HLA-DQ2 and 8, right? This will be something that is acquired, so it responds to antibiotics. Now, Whipple's disease, easy enough. T. Whippley, shoot. I don't know why my computer's doing this. Give me 1 second, I went too far. All right, you can see here, Whipple's disease, there's a few key things. T. Whippley is gonna be the causative agent. Let me find it. Joint pain is a big one you're looking for. So multi-organ problems, but so is celiac. So it's difficult. But Whipple's disease very commonly will give you these joint pains, okay? Not that celiac doesn't, but it's like one of the major things for Whipple's disease. So you want to look for that. Granulomatous inflammation. So, oh, here it is. PAS positive granules, okay? That's diagnostic for Whipple's disease. So you definitely need to know that. That's a giveaway for that, okay? That's probably what they will ask you on the test. And you can see here, diarrhea, weight loss, and joint pain, okay? So that's what you're looking for. Joint pain, PS positive granules, Whipple's disease, okay? All right, intestinal obstruction, right? Yeah, mostly functional, right? These hernias that form, volvulus. And you can see those here, any sort of herniation, adhesions that form. These adhesions are usually post-surgical problems. Volvulus is twisting, so you get decreased blood flow. Intussusception is telescoping, right? That you can see here. So this is painful, and you don't get proper digestion if that's the case. But again, you're looking at here at functional deficits here. All right, again, yeah, look, you see this in kids as well. You see this mostly in kids, and this is that telescoping of the upper aspect of the GI, usually in the large intestine, goes into the lower portions that you can see here. So it's kind of hard to have peristalsis, and it doesn't really correct itself because everything's trying to go unidirectionally, right? So you can't really pop it back out. Sometimes they could use retrograde fluid or dye or whatever to try to pop it back out, but that's really the only thing I've heard of, unless they go in surgically and correct it. Okay. Right, and this all kind of makes sense. That's what you would expect. All right, appendicitis, you've talked about this a lot. If you get stasis in the area, that leads to bacteria being able to proliferate, and then you can end up getting ischemia and inflammation. Mostly in young adults, it's, again, it's an acute problem. It can start epigastric. If it gets bad enough, you can get it in that McBurney's area, pressing on the peritoneum. There, McBurney's sign. Remember, you get that rebound tenderness as well. Yeah, so they could just go ahead and do an appendectomy here. And then you could also get tumors of the appendix, carcinoid tumors. So carcinoid, whenever you see carcinoid, you should think serotonin. So you get those classic serotonin signs, flushing and diarrhea, stuff like that. And of course, if it's serotonin, it has to be neuroendocrine as well, okay? So they can go ahead and do an appendectomy there as well, right? So the whole goal here is even seeing down here, you want to go ahead and do this appendectomy before it ruptures, especially if you have this mucinous neoplasm, because that could lead to a lot of disseminated bacterial infection and lead to sepsis and stuff. All right, pseudomyxoma peritoni, what is that? That's mucin. It's like a ton of mucin, right? It fills in the abdomen, right? These neoplasms as well. You can also see this from ovaries, colon, and pancreas, okay? So just one of those buzzwords you should have. You should just know that if you do get something like that, or even if they ask you there's an adenocarcinoma, what's a risk of that? You can get this mucin production. All right, y'all know about Hirschsprung's disease. Again, this is failure of neural crest cells migration. So you get this dilated, this megacolon. Classically, they say that the baby can't pass its first bowel movement, or meconium, which is the first bowel movement. And that's due to this lack of ganglion, these cells, so you don't get peristalsis at the lower aspect of the colon or the GI tract. So you get this functional obstruction, and you get this dilation of the proximal section. They joke the doctor has to kind of put his finger in, and you have to watch out because it's like explosive, right? I've seen questions like that. All right, and you can see that here. You get this dilation proximally, no ganglion cells here. So you need to kind of manually help to pass the stool, okay? Delayed passage of this first stool. That would make sense. So this is a congenital problem that forms. Failure of neurocrest cells, okay? I always like to ask that. Look, you can see it here. They put a retrograde dye in, squirted it up. This is the proximal portion. You don't see the ganglion cells here. So this is this dilated megacolon or sigmoid colon here. Then you get diverticular disease. Diverticulosis are like these little pouches that form. Diverticulitis is if those pouches get infected, okay? So primarily in the sigmoid colon, see this a lot in older patients, but these are these little outpouchings. Lack of dietary fiber can increase the intraluminal pressure, which can lead to these little outpouchings that form. Typically not a problem until you end up getting an infection here. So you can see these here. But if you do get an infection, diverticulitis, then you kind of need to be able to correct it. All right, good. All right, so we can look at the inflammatory bowel disease as well. So big differential here, you need to be able to differentiate Crohn's disease from ulcerative colitis. They kind of are, you know, there's some big differences here that help to be able to diagnose them or at least answer the questions here. Ulcerative colitis comes from the colon up the rectum, or sorry, from the rectum up to the colon, and it's linear, right? So it can grow upwards, but it's not going to form segments, right? It's just one collection at the terminal part of the, you know, the colon and large intestine. Whereas Crohn's disease has what's called skip lesions. So you could see it all the way around, even into the small intestine, but it doesn't, it's not necessarily, it's not continuous, okay? And Crohn's disease will be transmural. It can go all the way through, okay? All the way through the 3 layers. I think there's like a little chart that helps to differentiate them that's coming up. I don't think they actually ask you about what's really going on, just kind of like being able to diagnose these. Yeah, and you would expect malabsorption. Classically, it's like a watery diarrhea, which isn't what you'd think, but I'm pretty sure if it gets, but yeah, like if it gets bad enough, then you can get bloody and mucoid diarrhea, but they tend to have chronic malabsorption problems, chronic diarrhea, especially when they get these inflammatory episodes. So you could see these kind of go with this. Again, this is a autoimmune issue. With autoimmune problems come other autoimmune problems. Okay, so you could see these form as well with it. One of the big ones, it may come up later, but since we have it here, primary sclerosing cholangitis is very specific for ulcerative colitis. I think like 90% of people that have ulcerative colitis also have PSC. Okay, so you might want to write that in. But there was a bunch of board questions asking, like correlating those together because it's so common. And of course, you get this malignancy. What kind of malignancy would you think? Probably adenocarcinoma, right? Because it's a glandular tissue. All right, so Crohn's disease. These are these, you could see in red, these big buzzwords, skip lesions, right? So it's not continuous. If it was UC, you would see this continuous problem here. So you see these skip lesions that form, okay, all the way through. Sorry, not all the way through, but it can go all the way into the small intestines. Another big one, I actually had this on my last OSCE. Patient had bloody diarrhea. I was like, I don't know which one it is, but then she said she had ulcers in her mouth. I was like, okay, cool, it's Crohn's then. So that's a big thing that you'll see there. The earliest lesions are ulcers in the mouth, these aphthous ulcers, okay? Also, you get this cobblestone appearance. It's just kind of this mucosal irritation. If you were looking, you took a scope and looked, you would see like this kind of cobblestone or like this irritated appearance, this dry, not dry, but like this coarsely texture. That's a good way of putting it of the mucosa. Okay. And remember, here we go. It's transmural, okay? So it's going to go all the way through all 3 layers, okay? Because UC will only go through the first 2 layers. So some other buzzwords, right? So if it's active or acute, you're thinking neutrophils. Fissures can form because you're going through, these are fissures you see here. And crypt abscesses can form as well. So in these little areas, you could form crypts. Ulcerations, it's granulomatous as well, that forms. So these are all just big buzzwords that you can use to help diagnose it. All right, and look at this. This is more like this cobblestone appearance, right? Or this even right here. It's kind of, yeah, and non-caseating. Caseate, anytime you see caseating, you think tuberculosis. All other granulomas I could think of are non-caseating, non-cheesy or whatever. So non-caseating granulomas that form, fibrosis, and then this string sign as well. So these fissures, if they get bad enough, they could turn into strictures. And this is definitive of these string signs as well, these little tears, okay? And then here, this non-caseating granuloma, this little area here. Transmural, right, all the way through. If it says transmural, it cannot be ulcerative colitis. If it says it's transmural, it has to be Crohn's disease, okay? So use all these buzzwords to your advantage and you'll be able to differentiate. Now, look at the differences here. Now we're looking at this continuous fashion here, this colon and the rectum, right? So if it starts here, it will continuously go up until it stops, okay? So, yeah, it's not transmural, just the mucosa and submucosa. Okay, so it won't invade the muscularis like like Crohn's disease will. All right, pseudopolyps can form broad-based ulcerations. Okay. Pancolitis, right? Meaning all of it, right? And that just kind of defines it as continuous. And you could see here, look at it, this is the upper layer of it. So it went continuous all the way up from the rectum to the colon and then kind of stopped right there. Okay, so I mean, these are fair game pictures, right? Pancolitis, look, it goes all the way up. All right, probably stops right around there, maybe even goes to there. All right, and here you go. If you wanted everything kind of defined right here for you, these are the good ones. Sorry, this is the good slide for you to be able to differentiate them. But the questions I've seen are basically just diagnostically, right? So they'll give you the buzzwords and ask you what it is, or they'll give you the buzzwords and ask you a complication of it. Okay, so just keep those in mind. All right, now infections that could happen. The classic, what you call them, GI infections. So E. coli, Campylobacter, Salmonella, Shigella, right? A lot of these cause reactive arthritis too as well, right? So you're talking about what is reactive arthritis? Can't pee, can't see, can't climb a tree. So urethritis, conjunctivitis, and arthritis as well. Okay, so Campylobacter, Salmonella, Shigella, Yersinia as well. But yeah, so these can cause enterocolitis, or this inflammation, right? Which you would expect, as Lindsey was talking about, this diarrhea, stuff like that. All right, into amoeba histolytica, right? It can form in the sigmoid colon primarily, neutrophils that form, and this flask-shaped ulcers. Looking for anything that's super diagnostic for it. Is this bloody or, yeah, this is bloody, right? Anybody? Bloody diarrhea? Pretty sure.
Yeah.
Yes, yeah, bloody, thank you. Bloody diarrhea, so it's invasive. Here we go, invades scripts. Yeah, if it invades, it has to be bloody. Recruits neutrophils. All right, thank you. Right. Then typhoid fever, salmonella, yeah, you can get that. You really don't, we're not gonna talk about typhoid fever here. You're thinking more of the salmonella that's gonna cause this GI problem. So you can see that here, person to person or food. Yeah, this fecal oral transmission. Tuberculosis, as always, granulomatous infection, primarily in the lungs, as you know, but it can form down here, necrotizing granulomas and stuff. Not important. Pseudomembranous colitis, of course, when you hear that, you should think C. diff, Clostridium difficile. Patient comes in with whatever they have. They've been on antibiotics for a few days. Now all of a sudden they get bad diarrhea. That's C. diff, okay? Gram-positive, anaerobe. Remember, the further you go down the GI tract, the more anaerobes you're gonna find. So C. diff is all the way at the bottom, at the colon. So, and they have toxin A and toxin B. Those are, I'm not crazy about learning all the virulence factors, but those are some important ones. Toxin B is going to form these pseudomembranes. Okay, right. So definitely need to know that one, right? And the pseudomembrane formation, right? Not good. Then you can get ischemic bowel disease, right? So again, these are more like functional problems. If you have some sort of problem with blood flow there, even those sigmoid volvulus, those can cause restriction of blood flow. So, and you've learned about reperfusion injury. Whenever you bring blood back into it, you have all these reactive, ROS, reactive oxygen species. You know, the mitochondria get messed up, all the calcium flux. I don't know that that's super important right now, but yeah, you get all this damage here that you would worry about. So yeah, chronic, anytime you have some sort of, chronic problem, the first area you're going to worry about is these watershed areas, specific that splenic flexure. If you remember those, what are they called? Those marginal arteries are kind of what bring, those little side roads that bring blood to the watershed areas. Okay, so I see that. And any sort of acute problem is probably some sort of infection. So you're worried about this, this really bad E. coli, this hemorrhagic E. coli, 0517, could even lead to coagulative necrosis. Okay. All right. Whoops. All right, the neoplasias. Right, a lot of these came down to just having like a general understanding of a definition for it, right? So hyperplastic is just these epithelial proliferations. Don't think that that was a super important one, excuse me, to remember. Yeah, most common in the left colon. There's more important ones that are like more invasive or more problematic. Hematomas are really like, they're like, I think of them as like, if you like hammered them down, like they're very like erratic looking, these polyps. See what actually specific words they use for it, I guess. I don't know. If you look at them, they look like they're very much like all over the place. They're not like sessile or anything, like, small and like uniform. They're very all over the place. So you could see juvenile polyps or Petsch-Uger syndrome. Not sure if that really came up, to be honest with you guys. Juvenile polyps, you can see obviously in kids, it's an autosomal dominant problem. Yeah. Let's see, and then Peutz-Jeghers, a little bit older kids, increased risk of different malignancies, colon, pancreatic, and breast. Let's see. Oh, this is the one. Yeah. Okay, so they'll show, I've seen questions, they have the pictures, they have like these little blue markings, like they look like not a rash, but like just little, well, macules, I guess is the right word for it, on their lips. So that's a very, this hyperpigmentation is very characteristic of Peutz-Jeghers syndrome. Okay, so look for that. I think that's the main thing, at least that I can remember. So yeah, this would lead to these polyps. So if you see that on the lips, maybe key in on that there may be some sort of polyps forming. All right, and then adenomas, right? So it'll be benign. They can change into adenocarcinomas, this dysplasia, and there's different kinds. Tubular villus are the worst ones, right? They're like villains that can form. So yeah, and then you can even have the serrated kinds. Let's see if they get into more detail. Yeah. Yeah. So you can see these here. Can't remember any specific questions that came from these. Yeah, okay, so malignancy, if they ask you, like for instance, melanomas, the diagnostic clue for melanomas, not that you need to know this right now, is depth of invasion. That's how you diagnose melanomas. To be able to diagnose these, they could ask you what's the #1 diagnostic clue, it's size, okay? So the most important thing for these, which kind of makes sense, is how big they are. The bigger they are, the more risk of malignancy, it's more prominent dysplasia. Okay, so these sessile ones typically form in the right colon, the ascending colon, that you can see here, serrated architecture. We're gonna get to it in a second. The FAP and APCs, which is what they like to test on. So bear with me here. And then they go through the different pathways, but let's see. Here we go. All right, FAP. So this typically forms because of the mismatch repair problem, right? So you get these, I'm sorry, wait, that's the other one. Okay, so the FAP, the gene involved is APC. Okay, so these form like the thousands of polyps, right? So with thousands of polyps, there's thousands of opportunities for mutations. This will typically form in the descending colon, the left side, and because there are so many polyps, you're eventually going to get cancer. You're going to eventually get adenocarcinomas. So this needs to be monitored. This needs to be constantly addressed. Okay, so APC left side, that's the gene, the APC gene correlates to FAP, familial adenomatous polyposis. You're going to get adenocarcinoma. You have to address it because there's so many polyps. All right. Associated syndromes, not super important, but Gardner syndrome, if you remember, it has the heads involved with that, osteomas, and then turquoise syndrome involves the CNS. Just maybe keep in mind that if you see these, that relates to FAP. I don't know that I remember a test question coming up on those, but I think it's fair game. All right, so again, with FAP, you're going to get hundreds of these polyps that form. And again, the more polyps that form, the greater risk of cancer formation. Now, HNPCC is due to this inability to repair, this DNA repair problem, or it's also known as Lynch syndrome. These tend to form on the right side, the ascending colons. They're not as many of them. There'll just be a few of these, okay? So they're not as excessive as the FAP side. So again, for this lecture, by far the highest tested point is differentiating FAP from HNPCC. Okay, so also the DNA repair problem, know these MSH2 and MLH1, those correlate directly with HNPCC. Okay, so you would see typically these sessile type, okay? It's not as many right side, I mean, they'll be on the right side. Okay, so be able to differentiate those, hopefully. And no, they didn't give you a chart for those. Maybe check first aid, they might have a nice chart differentiating the two. All right, and then of course you can get colorectal cancer, adenocarcinoma. What is the tumor marker for colon cancer? CEA, right? CEA is the tumor marker for colon cancer. So definitely know that. And you can see there's a compilation of different things that forms. You have APC, then you have, you can get into having the second hit hypothesis, which goes into different mutations, CRAS, P53, a whole lot of different things that can form. The point is you have so many mutations, so many polyps, there's just so much opportunity for mutations to form. So it'll eventually lead to this adenocarcinoma. Right, and this MSA pathway, now we're looking at the HNPCC on the right side, the ascending colon, not as dangerous as FAP, but yeah, you're gonna get these sessile or sessile serrated adenomas, and it can also lead to adenocarcinoma, okay, BRAF and BAX, okay, microsatellite instability, that's the same thing. But if you can't correct the DNA, that's what you're gonna get, this instability. All right, so right side colon cancer, you're worried about iron deficiency, anemia, that's just because of the bleeding that's gonna form there, but remember right side's your HNPCC. Left side is gonna be narrower in diameter, right? So you're gonna get obstruction, that's you're talking about your FAP or all the thousands of polyps, okay? And here we go, tumor marker here, CEA, definitely need to know that. Prognostic factors here. Okay, so differentiating what we were looking at before, just those hemoromatous or those polyps where size was diagnostic. You can see here, important prognostic factors again is depth of invasion, which is super important because the deeper it invades, the closer it is to blood vessels or lymph or whatever. So high chance of metastasis. Okay, so that's important. And again, CEA. Right, and remember all of the GI tract, because it needs to be detoxified, drains into the liver, the portal system. So if that's the case, then the liver is a common place for metastasis. All right, some pictures, more pictures, right? And then you can see the liver has metastasis there. There we go. All right, APC gene, remember left side, definitely going to get cancer if you don't correct it or monitor it. MSI, you're worried about HNPCC, there's sessile, these are the genes involved, DNA mismatch repair, right, Lynch syndrome. All right, and then we kind of talked about Zollinger-Ellison syndrome, going to produce gastrin, which will lead to increased acid production there. So you're going to get not only ulcerations in the stomach, but in the duodenum and the jejunum too. That's pretty diagnostic there. Can lead to even carcinoid syndrome. So not only can it make, I think it can actually make gastrin, it could make serotonin or like VIP. But just worry about these because these are what's in your notes now. So gastrin, but it can even make serotonin and lead to carcinoid syndrome. All right, again, you can see here, that's where you get all these all of these ulcers. All right, and if you wanted to learn, know these, one of the buzzwords is salt and pepper pattern. I suppose that would be important to know for these neuroendocrine tumors, these carcinoid tumors. All right, so I don't know that this was super important. Just remember that malt lymphomas is a complication of H. pylori. That's a big one there. Yeah, Peyer's patches, that's where you get all of these that's lymphoid tissue. And here you go, H. pylori is most common inducer in the stomach. Okay, you get malt lymphomas. Awesome. All right, liver, everybody loves the liver stuff. All right, so now when you look at the zones, zone 1 is that oxygenated blood, okay? Zone 3, when you get to the central vein, as the blood gets detoxified and gets to the central vein, it loses oxygen. So zone 1 is most susceptible to toxins, okay? These toxins are coming directly in. Zone 3 is most susceptible to ischemia. That's because it's the furthest away. It's getting the least amount of oxygen. Okay, so first zone, toxin problems. Third zone, oxygen issues, hypoxia. Okay, I kind of know your labs at this point. Let's get to the pathology. Right. All right, so fatty liver steatosis. That's what that means. It's usually an acute complication of some sort of binge drinking or alcohol or acute alcohol problems, but there are also some other ones that can cause fatty liver that we'll look at as well. And then there's some microvascular problems which aren't as common. Yeah, you would expect these signs. Y'all know these by now. Murphy's sign is when you press down on that right upper quadrant and they stop breathing. You ask them to take a deep breath and they feel pain and they stop breathing. All right, and then chronic problems, portal hypertension, you would get these symptoms, stuff like that. Yeah, right, so yeah. Remember that when you have chronic hepatitis or even cirrhosis, you end up making more estrogen, and that's why you can lead to this gynecomastia testicular atrophy as well, okay? And then jaundice, yeah, you expect kernicterus if you get bilirubin in the brain. That can happen anytime. Typically, bile salts. If you're retaining bile salts, that leads to itching. That's usually a common thing that you'll see. And then, of course, a lot of cholesterol could lead to these xanthomas. All right, again, let's get to so acute liver failure. Right. So I guess the time frame's kind of important. You can get this within 26 weeks, acute liver failure. But if it's fulminant, meaning full blown, if you get encephalopathy, problems in the brain, within 8 weeks of the onset, you're thinking fulminant or full blown liver failure. Yeah, that's what you would expect. Not only steatosis, but you go from steatosis, fatty liver to full blown necrosis, like you're getting into the cirrhotic area, and then there's no return from that. All right. Okay. Acetaminophen, big one there. It doesn't take much, but an overdose of acetaminophen could lead to full blown necrosis. That's the one they really like to test on. Let me kind of break it down here for you guys. All right, so what can cause chronic liver failure? Hepatitis B and C, obviously. Remember, A and E kind of go together. That's just an acute response. It's a GI issue mostly. B and C is the chronic problem, and that could lead to cirrhosis. And then you have these other problems, well, alcohol liver disease, but this non-alcoholic problem we'll look at in a little bit too. Right, and these ETO cells, that's what leads to the fibrosis. Okay, pictures, yeah, hepatic fibrosis. And you get this nodule formation. By that point, you're looking at, this fibrosis is leading to cirrhosis. Okay, so good picture here. You see these nodules that are forming this connective tissue in between. That's what's forming these nodules. All right, so this is kind of an outline that will go through these different problems here. See. So again, a complication of cirrhosis, as you know, is portal hypertension. You get these pathologic anastomoses, lead to varices or this congestion of these veins, can lead to problems, esophagus, abdominal wall, and rectum form, but you are aware of those now, these shunts that form. All right, so like we said, hepatitis B and C are the big ones that'll cause chronic liver failure. Remember, D goes with B. Super important. I know Lindsey touched on it. You need to know the labs for hepatitis B. So by seeing what components of the antigen or antibodies are there, you can tell what's the state, if the patient's vaccinated or if they're recovering or whatnot. Look at first aid for that, but you can see that there. All right, let's see. Right, and you can see this here. What are the complications? You can get acute. It could lead to fulminant hepatitis. It could even lead to, or it can lead to a chronic hepatitis. You can recover. So there's a whole host of problems. And remember, anytime you get cirrhosis, you're at risk for hepatocellular carcinoma. Okay, so anything that's going to lead to long-term complications, liver failure, chronic liver problems, you're at risk for hepatocellular carcinoma. Okay, yeah. Chronic hep B, a good buzzword for you, this ground glass appearance. It kind of looks smooth, shiny, kind of. But yeah, that's what they're trying to refer to with these areas here. It kind of has this shiny glass appearance. Okay. Remember, the big one is if the patient is only positive for so it has the antibody for HBS. If that's the only thing there, that doesn't mean they have the infection. That means they were vaccinated. The actual vaccine is a surface. You develop surface antibodies. Okay, so make sure you know that. Go back and look. That's a good thing to check on in first aid and stuff. All right, and then of course you can get autoimmune problems, autoimmune hepatitis here. These are important to be able for diagnostically, this anti-nuclear antibodies and anti-smooth muscle antibodies. And then in kids, they didn't really ask this, but this anti-liver kidney microsomal type. But know these, they could ask you, there's some sort of autoimmune problem that's causing, patient comes with jaundice and stuff like that. What would you look for? These are what you're looking for. Okay, plasma cells as well. Then alcoholic liver disease. So this is steatosis. This is this fatty liver that's forming. You can see this. And of course, if it's not corrected or if it's a continuous problem, it could lead to hepatitis and then fibrosis. Okay. Yeah. Right. And you can see what happens here. So you get this fatty liver, binge drinking for a little bit. So an acute problem, it can fix itself. It could lead to cirrhosis. It can lead to full-blown hepatitis. I'm sorry, it could lead to, you could have steatosis or you could have hepatitis as well. But it could either correct itself or it could lead to full-blown cirrhosis. Now, remember, with cirrhosis, you are worried about hepatocellular carcinoma as well. Then I have here, remember, one of the key things for hepatitis is these Mallory bodies or Mallory-Dank bodies. Excuse me, those are keratin inclusions. And you can see that here, right? Right. So, here you go, these eosinophilic inclusions. And ballooned hepatocytes are characteristic of acute infection as well. All right, so what if you have liver disease that's not caused by alcohol? They have this non-alcoholic fatty liver disease. Usually that's related to diabetes or insulin resistance. So all four of these in my mind kind of go together. insulin resistance related to obesity, diabetes, hyperlipidemia. So it does give a similar presentation to alcoholic liver disease. It could lead from fatty liver all the way to fibrosis. Okay, and you can kind of look at that, how it breaks down here. All right, I guess the next lecture goes into it a little bit more. And when we'll do this one, and then I think there's one more, and then we'll take a break, and then we'll look at the drugs really quick. All right, so the big thing between these two, you need to be able to differentiate primary biliary cholangitis from primary sclerosing cholangitis. Okay, so hopefully there's a chart or something. I think there is. That'll help you differentiate these. So primary biliary cholangitis, autoimmune problem. Big thing here, if you're looking to diagnose this, anti-mitochondrial antibodies, okay? So when you talk about feathery degeneration, that's cholestasis or stasis of the bile. And then of course, if there's any sort of hepatocyte damage, you're having these Mallory-Dank bodies, okay? You can see an elevated alk phos and gamma glutamyl transferase or GGT. And those, of course, are a problem with bile retention, okay? So problem with the gallbladder, you would expect both of these to be elevated. All right. And then contrasting, you have primary sclerosing cholangitis. Remember I said the big thing to remember is that correlates with ulcerative colitis, I think about 90% of the time. If you're trying to diagnose this, you look for p-ANCA, okay, anti-neutrophil cytoplasmic antibodies, okay? That's what you would expect there, and you would get an elevated alk phos, okay? Another big buzzword here, onion skin lesions that they like to test on, or that came up too. So that's characteristic of sclerosing cholangitis. Okay, and this is this onion skin appearance that you could see here. Yes, this is it. All right, star of this slide. This is what you want to know. Yeah, so primary sclerosing, it says irritable bowel disease or inflammatory bowel disease, but you should write in there specifically ulcerative colitis 70% of the time. All right, and then if we were to diagnose it, anti-mitochondrial antibodies for primary biliary cholangitis and p-ANCA for sclerosing cholangitis. Okay, those are the big ones you want to know. I think there was another, oh, here we, okay. Maybe write this in. Primary biliary cholangitis is just intrahepatic ducts. Doesn't exactly say that. But primary sclerosing cholangitis is intra and extrahepatic ducts. That's another big differential for these two. Okay, so this biliary cholangitis will deal with small ducts versus medium in sclerosing. Okay, I think that's the big differentials there. All right, and then hemochromatosis, the gene involved is the HFE gene. You need to know that. So this is where you get that bronze diabetes, okay? The buildup, that you can see here, these iron builds up, and then due to this genetic mutation, what you end up getting is, because this is mutated, you don't have a restriction on the amount of iron you're taking in from the gut. Okay, so you just bring it all in and you get just an abundance of iron everywhere. Okay, so that will lead to the bronze diabetes that forms, right? Iron overload, oh, no, these are just different causes, okay. Yeah, so of course you would expect to see higher serum iron. Ferritin is the storage form of iron, so you'd expect to see that elevated as well. Because it's the HFE gene, you would expect it to be familial. All right, so yeah, you check the tissue iron, that's a gold standard. If it's elevated, then you pretty much got it. Problems here, it could lead to hepatocellular carcinoma. If it develops in the pancreas, it'll knock out the pancreatic cells, so you get diabetes. This bronze diabetes is, it's due to iron deposits, but you actually get an elevated of melanin as well for whatever reason, but that's what causes that bronzing. But if you ever see a patient that's brown, it's either going to be Addison's disease or hemochromatosis. So if it's on this test, well, no, actually, y'all covered endocrine too. So it could be one of those two. All right. You can see these iron deposits here. Right, atrophic testes is another thing that is commonly seen here. All right, Wilson's disease is a mutation. You need another gene, ATP7B gene, so you don't properly make seroplasmin, right? You don't get it into you don't make seroplasmin. You don't get the iron into the transported form to get it into bile. So if you can't get it into bile, you get deposits everywhere. These iron deposits, Clarifier rings. Those are characteristic of, I'm sorry, did I say iron? I mean copper deposits in the eye, okay, that you can see there. But you also get copper deposits in the basal ganglia, so you can get these neuropsychiatric symptoms as well. So look out for that. And of course, any sort of hepatocyte damage, if you see that, the Mallory-Dank bodies are common, okay? All right, alpha-1 antitrypsin, y'all have covered a number of times. If the PIMM gene converts to the homozygous PIZZ, that's pretty bad. Remember, alpha-1 antitrypsin causes not only lung problems, but liver problems as well. So you get this pan-acinar emphysema, similar to, similar to the normal emphysema from smoking, but this is pan-acinar. So that's characteristic for alpha-1 antitrypsin. But you also get hepatocellular accumulation of this protein, okay? So that'll lead to hepatitis at a pretty young age. All right, and then you see these inclusions, right? These are these misfolded proteins that form. That's super important. It's kind of asymptomatic. I don't remember them asking about this either. Right, adenomas, again, benign. Oral contraceptives or steroids. I don't remember them asking about this, but this seems like it'd be fair game. Knowing which goes with, or which can lead to this. Maybe know these three. Hepatoblastoma. So blast cells are primitive cells. I don't remember this really coming up either. Alpha fetoprotein elevated. That seems like that would be important. Again, it's a childhood problem. Usually when you see blastomas or blast problems, since these are primitive cells, they're usually like neuroblastoma is a childhood problem. So blast problems are usually in childhood. But I don't think this was very high yield. This, of course, is very high yield. Anytime you have cirrhosis, you can end up getting hepatocellular carcinoma. Hepatitis B is a big one. Alcoholic cirrhosis can lead to HCC as well. Yeah. So big thing here, the diagnostic clue is elevated alpha fetoprotein. Okay, if you get that, you need to be thinking of hepatocellular carcinoma. All right, and of course, with any cirrhosis or hepatocellular carcinoma, you're worried about portal hypertension as well. Okay. Right, that's what you would see, increased hepatocellular carcinoma. Also see that yolk sac tumors, because we're going to do repro tomorrow, that's fair game, but you can see it specifically right now with this. Don't think this was important. Cholangiocarcinoma. Oh yeah. One of the rare instances where some sort of infection can lead directly to cancer. Okay, so maybe just knowing these bugs here, I think that there's some other parasites that they specifically, but this top one looks familiar. I don't know about that, but that could lead to sort of some cancers. Okay, so if they were talking about some sort of right upper quadrant pain, you were thinking maybe it's cirrhosis or HCC, but the normal AFP, maybe go your second line, second diagnosis, maybe some sort of infection, it's cholangiocarcinoma. Okay. Fever, cholangitis, yeah. Yeah, see that, yeah, that one's more important than the other one. Clenorchis sinensis, whatever, brutal, murdered that name, however you say that, right? So there's a fluke infection that could cause cancer. Good test question. All right, and then of course, anytime you have metastasis, especially the GI tract, all the blood of the GI tract drains into the liver. So it's going to be the first site of metastasis, GI, colon, stomach, pancreas, breast and lung as well. Okay, but right now that, that's what you need to think of. All right, I think we got one more and we can take a break. What is this? Oh, pancreas. All right, so a bunch of weird words. Cholelithiasis is stones, right? Stones in the gallbladder. Cholecystitis, remember, itis is inflammation. So this is inflammation. Usually it's secondary to stones. And of course you get neoplasms as well. All right. Cholelithiasis, we have our 4 Fs, female, fat, 40, fertile, okay? Classically, you can get these bilirubin calcium stones. Classically, you get cholesterol stones, okay? High cholesterol diet, fatty foods, stuff like that. But you can also get bilirubin stones. Remember, if you have some sort of hemolysis that's dumping bilirubin into the blood, a lot of time it's got to go somewhere. So it ends up, kind of coalescing or coalescing in the gallbladder. So you get these bilirubin stones. So differences here. Bilirubin are these black stones or pigment. Bilirubin always gives pigment. And then these cholesterol stones. Look how many. You got to get a bunch too before you even are diagnosed. Even before you start feeling pain, right? So you can see those here. And then the bilirubin stones. So again, what are we talking about? We're talking about a high cholesterol diet, right? This female, fat, 40, fertile. That's what we're talking about here. With these pigmented stones, you have to have elevated bilirubin. What causes that? A lot of times that is a lot of hemolysis, prehepatic jaundice, right? So this prehepatic, you're lysing a lot of red blood cells, you lose a lot of bilirubin, the bilirubin gets to the liver, it's too much, they start to form these stones in the gallbladder, okay? Intravascular hemolysis, yeah. All right, we talked about Murphy's sign, right? I mean, if you have some sort of inflammation, anytime the patient takes a deep breath and you're kind of pressing down, they'll stop breathing. That's Murphy's sign, indicative that there's some sort of gallbladder or underlying inflammation there. And there is your 4 Fs. All right, cholecystitis, right? So you're looking at inflammation of the gallbladder. And again, like I said, primary caused by gallstones, okay? Could get ischemia as well. But again, the questions they'll ask will probably be about gallstones. Right, it could lead to even a chronic formation, this porcelain gallbladder that forms is just completely calcified. It's not really mobile. Calcification of the wall, I guess. I don't think this is, I mean, I would assume that the patient would feel the pain and go to the doctor and get this addressed before you get to this point, but who knows? All right, and you can even get carcinoma of the gallbladder, gallstones, adenocarcinoma, again, glandular tissue. So you're worried about adenocarcinomas, okay? Is that, no, it's not it. All right, biliary tree problems. Okay, cholelithiasis. So this is not only inflammation of the gallbladder, cholelithiasis, or I'm sorry, actually, this is cholelithiasis is the biliary tree. Okay, cholelithiasis. That means you have gallstones in the biliary tree. Cholangitis means you have inflammation of the biliary tree. Okay, so make sure you get these words straight. Anytime, so it's cholelithiasis is stones, cholelithiasis is the tree, stones in the tree. So it actually got out of the gallbladder, they got stuck in the biliary tree. Cholangitis is the tree, and you get you get inflammation. So angitis, right? Angitis, inflammation, cholangitis. All right. So this could of course lead to obstruction of impaired bile flow. So if you don't have bile, you can't absorb fat, or fat soluble vitamins, pale stools, that whole thing. All right. yeah, it can even lead to cyst formation. All right, again, common bile duct, most frequently involved. So it gets down through the biliary tree and then it gets stuck in the common bile duct. I'm not sure if this Marizzi syndrome, don't think that came up, but this, if it's impacted in the cystic duct before it gets to the common bile duct, there you go. Oh, it's stuck in the cystic duct, then it kind of compresses against the hepatic duct. Okay, so you get obstructive jaundice if you can't get drainage from the liver. But most frequently, when you get this choledocholithiasis or stones in the biliary tree, it's going to be in the common bile duct. Now, inflammation of the biliary tree, you can get some bugs here, some gut bacteria, E. coli, always a culprit, Enterobacter. And then, of course, cholangitis, a big one, this triad, Charcot's triad, fever, right upper quadrant pain, and jaundice. Okay, so if you see those, you could think of cholangitis. Now, of course, if you have stones in the biliary tree, you can also end up with inflammation there. But again, Charcot's triad is very common if you have inflammation there. Okay, and yeah, it could even be a liver fluke. So you could get inflammation from some sort of infection or stones, but yeah, just keep those separate in your mind. Yeah, any sort of malabsorption, y'all know about cystic fibrosis. Of course, if it can't regulate that chloride secretion, you can't regulate water secretion, you get mucus buildup, then this pancreatic duct gets clogged and you can't get pancreatic juices or enzymes out, so you end up with malabsorption, okay? Classically cystic fibrosis, that's what happens. So if you don't get that, you can't absorb fats, you can't absorb fat-soluble vitamins, so the compilation of that is those fatty stools, okay? You malnourished because you can't absorb fats or fat-soluble vitamins. Okay, so y'all know about this. This should be easy points. All right, yeah, y'all know this. Of course, the mucus builds up in the lungs and the pancreas, all that stuff, men are infertile, all that. Yeah, and you can see the compilation of symptoms here. Acute pancreatitis, very importantly, which you may not think intuitively. So acute pancreatitis, of course, you're gonna get elevated amylase and lipase. But if you have chronic pancreatitis, your amylase and lipase return to baseline, okay? So if you have elevated amylase and lipase, it is acute pancreatitis, okay? If it goes back to baseline, then it can be chronic, okay? So again, if it's elevated, you immediately rule out chronic, it's an acute issue. All right, so a bunch of things I forget the mnemonic for this. I don't know, somebody could put it in the chat. But predominantly, by far, gallstones and alcohol are gonna cause this acute pancreatitis, okay? Shoot, I forget. Somebody can say it aloud if they want. Yeah, anyway. All right, right, so you'd see this elevated amylase and lipase. Now, hypocalcemia is a common problem for this because what happens in the acute pancreatitis is it kind of absorbs this calcium. You get like this, these calcium deposits there, which will lead to hypocalcemia. Okay, so that's very characteristic. So along with amylase and lipase, keep in mind that hypocalcemia is a diagnostic clue for acute pancreatitis. Okay. Some of these are not very intuitive, but yeah, keep those in mind. ARDS, ATN, pancreatic abscess, okay, or complications, you know, these calcium abscess that form, these calcium deposits leading to abscess. All right, and this fat necrosis, right? Of course, pancreas is very commonplace. The major place that I can think of off the top of my head that causes fat necrosis, okay? Right. This acute inflammation is reversible. All right, then again, chronic pancreatitis, you will not get an elevated amylase and lipase, okay? So long-term alcohol abuse can happen here. You eventually get fibrosis, which is not reversible. Here you see it's irreversible, and atrophy and dilation of the ducts. Calcifications, again, right? So if there's calcification, you may end up seeing hypocalcemia again, just because all of this calcification in the pancreas that forms. And of course, there's a risk of adenocarcinoma with that as well. And of course, if the pancreas isn't working, it's all calcified, all this fat necrosis going on, and this fibrosis in the chronic form can definitely lead to diabetes as well. All right. And then adenocarcinoma, number one thing you need to think about is smoking. Maybe not intuitive, you think lung cancer, but pancreatic adenocarcinoma, they like to talk about smoking. And that, if you have some sort of cancer in the head of the pancreas, a lot of times that can press on the on the common bile duct. Okay, so sometimes when you get this adenocarcinoma, you'll get elevated AST, ALT, ALP, GGT. That's from the compression of the head of the pancreas. But then you'll get elevated amylase and lipase as well. You get hypocalcemia. So just remember, if there's a tumor at the head of the pancreas, it can compress against the common bile duct. But again, smoking is a big one for this. And sorry, that's versus chronic pancreatitis, which, like, when you think of chronic pancreatitis, think of alcohol. When you think of pancreatic adenocarcinoma, think of smoking. Okay, so some of the problems: Trousseau syndrome. You get these vascular, thrombophlebitis, this clots that form. They don't embolize, but they just form in the vessels. This Trousseau sign. And very, very importantly, we said with colon cancer, CEA is the marker. With pancreatic cancer, CA19-9 is the marker you need to be aware of, okay? Pancreatic adenocarcinoma, right? And we have obstruction here. The head of the pancreas is obstructing on this common bile duct here, like we were talking about. All right, and then you can get islet cell tumors, beta cells, alpha cells, or whatnot, even gastrinomas, like Zollinger-Ellison syndrome. Okay, so those can form there. Beta cells, yeah, we were talking about Zollinger-Ellison, right? So we expect all those ulcers that form. It is associated with MEN. I guess we'll cover that tomorrow. MEN1 specifically with those pancreatic cancers. Insulinoma, Whipple's triad is a good thing to know. They kind of go together. If you have low blood glucose, then obviously you're going to get symptoms of hypoglycemia, which will obviously be fixed when you give glucose, right? That's what you would expect. But these patients will come in just their blood glucose levels are like 30 constantly, and that's because they're constantly secreting insulin. Okay, so good for that. All right, cool. That was fun. I guess let's take a 5-minute break, and I will do my best with these drugs. So I think with a lot of the drugs, fortunately, the questions are fairly straightforward. They ask you mechanism of action and side effects. Okay, so I'll just try to point out some of the big ones here. All right, so this is just kind of talking about clinical problems, and then we'll get into the actual drugs in a second. I guess this is, I forget his name. What's his name? I like him. He's a good teacher. Oh no, sorry, she's a good teacher too. Never mind. Sorry, I'm losing it. All right, here we go. Antacids. So big thing here you want to remember is that it's very different in these side effects, right? Aluminum will lead to constipation. Magnesium will lead to diarrhea. So if you have a patient that has problems with acid, too much acid or GERD, but they also have some sort of problem like constipation or diarrhea, you need to give them the opposite. Okay, make sure because that's the kind of thing that they could ask on the test. All right, so H2 is found in the GI tract. That'll produce acid. This histamine will help induce acid. So if you could block histamine, like cimetidine, famotidine, these are over-the-counter things. Famotidine is Pepcid, things like that. You will be able to help with the acid production. Right, so basal gastric acid, you're talking about just not with meals, so just the baseline. So if you have it really predominant throughout the day, not necessarily correlating to meals, you can maybe use the H2 antagonist. But honestly, you're not, you just take whatever works clinically. Right, so this makes sense. Any sort of increased acid you do there. But if you increase the gastric acid pH too much, you can cause B12 deficiency. It can lead to B12 deficiency there. You're kind of inhibiting those parietal cells. So that could lead to that with chronic use. Cimetidine, I don't know that they don't really use this anymore. You can use famotidine and stuff like that because cimetidine has all of these anti-androgen effects, stuff like that. But that might be a good test question, even though, like I said, they don't really use it too much. And it's an inhibitor of your CYPs. So that's problematic too. All right, but classically you use things like over-the-counter Prilosec. That's a 24-hour pill you could use. Inhibits gastric acid secretion, this proton pump. So these work very well. First-line treatment, right? Can work over here in that final common step. Right, so it can work on basal and meal-stimulated gastric acid because it's preventing the hydrogen from getting into the lumen. So yeah. Omeprazole, that's Prilosec, I believe. Omeprazole, anything with the prozols. Okay, so yeah. Peptic ulcer disease, H. pylori, NSAIDs, those are your main things that you'd want to use those for. Yeah, but omeprazole does have the effects. I think it says on the Prilosec on the box, you're only supposed to use it for like 2 weeks at a time, but it works very well. Yeah, so can inhibit CYPs. Clopidogrel is a blood thinner. So again, these are just some of those things, unfortunately, you just have to sit down and memorize. But H. pylori, big thing, triple therapy. Use 2 antibiotics. Y'all cover the antibiotics in term 5. It's kind of a pain, but you use 2 antibiotics with a PPI. But y'all will get into that later. Or you can actually add Pepto-Bismol, which is this. All right, then mucosal protection. We know prostaglandins, that's why NSAIDs, because they inhibit prostaglandins, that's why they cause ulceration. But misoprostol is a prostaglandin analog, so it can help to protect that mucosal barrier and vasodilate the area so you can get repair in that area. But yeah, one of the side effects is it's an abortifactin effects, so you don't, you have to be careful with that with pregnancy for sure. Sucralfate will kind of line this area here. So this irritated area will help with resolution of the inflammation. The irritation won't get worse. Physical barrier. Bismuth is Pepto-Bismol, right? So it's used in this quadruple therapy. It'll help with H. pylori. So that's good there. And then prokinetic drugs are pro-movement, like motilin, serotonin. So these prokinetic agents can help with constipation and gastroparesis and stuff like that. So specifically diabetic gastroparesis or inability, or you don't get movement of the food bolus from the stomach to the GI, to the small intestine. So it's a neurogenic problem from diabetes. It happens in a lot of different things. Medications can cause gastroparesis as well. So if you can have an agonist of motilin, such as erythromycin, you could help with the movement of food. And then serotonin. So the idea here, this is a 5-HT4 agonist and a 5-H3 antagonist of serotonin. But overall, it has this, it's a stimulant of smooth muscle, so it'll help with that motility, it'll help with peristalsis, so it'll help with GERD and gastroparesis. And you can see here, similar principle, metoclopramide, serotonin, it works on these serotonin receptors, but it also has a D2 receptor antagonist. So by doing that, it's very similar to, these anti-Parkinson's drugs. Sorry, not anti-Parkinson's, these schizophrenic drugs, right? So the schizophrenic drugs have a D2 receptor antagonist, and they could lead to extrapyramidal side effects. And you could see that here by antagonizing the dopamine receptor, you can get extrapyramidal side effects, which is like motor movements, okay? It can also lead to galactorrhea because if you block dopamine, remember dopamine helps to antagonize prolactin. So if you block dopamine, you can get excessive prolactin secretion. Okay, so again, for these drugs, don't dive too deeply, just know kind of how they work and a few of the major side effects, and you should be good. All right, what are we doing here? Antiemetics. All right, great. So scopolamine, typically motion sickness. Yeah, I guess you could use it. That's what I think of it as. I guess you could use it in normal nausea and vomiting, but not chemotherapy. I think of this as just a motion sickness medication, scopolamine. Then you have these H1. Now remember, H2 is going to deal with your acid. H1 is going to deal with this antiemetic or antimuscarinics. So diphenhydramine, Benadryl will actually help not only with the allergic effects of H1, but also this anti-emetic or these, antiemetic effects, meclizine and cyclizine as well. Okay, so these actually work on these vestibular sensory fibers in the brainstem to help with the hyperemesis. Promethazine is Phenergan. It causes like sedation almost, but it does help it's a dopamine 2 antagonist, so it works as an antiemetic. It specifically works on this chemoreceptor trigger zone. Okay, so not really, they don't use it in chemotherapy as much, but it can be used for emesis. Now there's some chemotherapy induced, obviously that causes a lot of hyperemesis. So some of these drugs work so well. Ondansetron is Zofran. It's probably the best antiemetic around. They don't just use it for cancer, they use it for everything. It works really well. It doesn't have a lot of side effects. So Zofran is a good thing to use. Ondansetron, you'll come across that a lot. So you can use that primarily, at least in the lectures, it talks about it in regards to chemo, but it's safe in pregnancy, as you can see here as well. Okay, then you have these. I don't know that these were super important, but they antagonize substance P, I think for pain, but you could see that. So they can help with this, but I don't remember these coming up, these neurokinin antagonists. Then corticosteroids, for whatever reason, they work as well in nausea, suppress peritoneal inflammation and prostaglandin production. Okay, dexamethasone and methylprednisolone. Okay, don't really think that came up as well. They asked about like ondansetron. They really like that one a lot. Metoclopramide's a big one that they talk about. It's those H2, those H2 antagonists with acid and stuff like that, proton pump inhibitors. But this stuff I don't remember this being super important. Benzos kind of, have this, GABA has that inhibitory effect on the CNS. So if you can inhibit the CNS with, lorazepam, alloprazolam, I believe is Xanax, diazepam. So these things will help with nausea in the CNS, right? CNS with GABA. All right, so those can work as well. And then marijuana, of course, works. Dronabinol is I think the pill form of it, right? So this cannabinoid 1 receptors, the brainstem, obviously that works. Medical marijuana is used in a lot of states to help with chemo-induced nausea. All right, marijuana like highs. Yeah, so this. All right, cool. All right, laxatives. I think the main thing here is just knowing the mechanism of action of like how the different types of laxatives work. So there's bulk forming. Those would be these. Okay, so you absorb water from this to promote peristalsis. Okay, so these are the ones you want to kind of compartmentalize as these bulk forming laxatives. So these are stimulant laxatives. So if there's some sort of problem with motility, you can give these. Senokot is over the counter that you could use. You can castor oil, bisacodyl. Yeah, so again, keep these together as stimulant laxatives versus the bulk forming. Then there's stool softeners. If you have constipation, you can give Ducasat, glycerin. So stool softeners plus lubricant, mineral oil can be used as well. Again, these are just things you just have to go through and memorize. Osmotics, so anything that's going to pull water into the lumen. So stuff like lactulose or magnesium salts. will help to bring water in, and that will help with any sort of constipation. Polyethylene glycol, also an osmotic agent as well. Lubipristone as a laxative, it works on these chloride channels. So if you bring chloride into the lumen, you get intestinal mobility as well. And then, so you know that opioids cause constipation. So these are mu opioid antagonists in the gut. So if you can block those, you can help with this this opioid induced constipation. So these are going to be your medications that you can use there. All right, then antidiarrheals. Loperamide works. So it's an opioid agonist, but you don't get those opioid effects from it. Okay, so this is actually commonly used. You use the effect that opioids can have with to promote constipation in these diarrheal instances, but this won't give you any sort of opioid-induced highs or anything. Diphenoxylate can be used as well, but loperamide is the one that, at least in the questions, I've seen more often. All right, you don't want to give opioids to kids and stuff like that. Even if they're safer opioids, you just don't. All right, so somatostatin. Remember, somatostatin has that effect to kind of like slow everything down. It inhibits insulin, glucagon, all that stuff. So ectreotide, this is a commonly tested thing. It is a somatostatin analog. I believe, oh yeah, here it is. It can be used for stuff like Zollinger-Ellison syndrome, for like carcinoid and VIPomas, because it kind of inhibits everything to slow things down. So I think that's more of the thing they test on there than the antidiarrheal effect. But knowing that would be good. Yeah, and it does have adverse effects here. By slowing everything down, you get decreased exocrine, those gastric enzymes secreted from the pancreas, and you get inhibition of gallbladder contraction as well. Okay, and then Pepto-Bismol again can help with traveler's diarrhea and stuff like that. All right, IBS, so it gets a little more complicated here. The Lubipristone came up again with this chloride channel activator. Again, you can give loperamide for that diarrhea as well. Allosetron, I guess is how you say that. And that work on serotonin, and then anticholinergics as well can help with IBS. I guess depending on the degree of IBS you have, you can use that situationally or on a regular basis. All right, IBD. Yeah, so remember, irritable bowel disease is typically going to be caused by, you're going to have a lot, autoimmune problems. So if that's the case, if it's bad enough, you need to have immunomodulators as well. So this is where it gets a little bit more complicated. So, right, so you can give these aminosalicylates, sulfasalazine, it's a sulfa drug, so you have to be careful with that. So this is the first line drug you're going to give 5-ASA for things like Crohn's disease and UC, because it'll kind of help with these ulcerations and stuff. So yeah, you can give that would be the first line. If they had put that in the question, that's the first line drug you want to give. Yeah, and this is kind of the mechanism of action for that. So good to know that there. Yeah, kind of goes into how it works. Again, there's a lot of slides on it. Consider it important first line drug for these situations, inflammatory bowel disease. And then, whoops. Okay. Okay, anyway, so glucocorticoids, of course, sorry, let me just, my computer's acting up. Right, so, right, I don't know if it's super important to know these, but again, first line drug, these aminosalicylates, can give kind of generic Side effects, except these myalgias, bone marrow suppression. Again, you're suppressing this inflammation. So by doing that, you can get things like bone marrow suppression. So that would be one to star there. And then there's some other ones, mesclamine. But again, 5-ASA is usually at least the one I've seen tested on. All right, and then of course, glucocorticoids will help to decrease inflammation in and of themselves. Inhibits phospholipase A2, it inhibits cyclooxygenase, but it also has an effect that NFKB as well. So to overall decrease inflammation, just systemic decreasing of inflammation. Hydrocortisone can be given specifically, enema there. But of course, you can see here, anytime you give corticosteroids, you don't want to give them long-term. You could see here, you're going to suppress your ability to make cortisol altogether. That immunosuppression long-term is not necessarily good. Hyperglycemia as well, because it is a glucocorticoid, it acts like cortisol. And big problem here is osteoporosis. That's really why you don't want to give these glucocorticoids long-term. All right, budesonide, another one. All right, so these are a little bit stronger, right? These purine metabolites, if you help to, yeah. So again, you can give these, they're not steroids, so you don't get those steroid effects. They are hepatotoxic. Bone marrow depression, not necessarily suppression, which is worse, but azathioprine, mercaptopurine, purine metabolites, okay? Allopurinol, that works on gout, okay? So if you reduces xanthine oxidase, so that could be used as well. Methotrexate, and remember, these are anti-cancer drugs also, so you're inhibiting proliferation of these amino acids and stuff, so you're not going to get proliferation. So this methotrexate, if you remember from way back, dihydrofolate reductase, okay, so anti-proliferative effects. So if you're not making all these new cells, you're not making inflammatory cells, it'll help with the inflammation. Okay. Yeah, imatinib, right? Tyrosine kinase inhibitor. No, I'm sorry, this is not imatinib. Infliximab, right? MAB, monoclonal antibody, right? So these are even stronger drugs. These things like Crohn's disease have tumor necrosis factors that kind of promotes this inflammation. So infliximab, adalimumab, you've probably seen commercials for this. So this is for moderate problems. So the whole goal with these are to block this tumor necrosis factor. That's a major player in making cytokines, acute phase reactants, stuff like that. So if you could block that, you're going a long way. But again, these are for moderate problems here. All right. Now, again, if you're modulating or decreasing the immune system in the GI tract, you're also going to decrease it in other places. So you can end up with invasive fungal problems or reactivation of tuberculosis and stuff like that. And again, a monoclonal antibody. This is specific for integrins. Don't know really how high yield that is, but yeah. Right. So yeah, and then kind of going on a different avenue here. Anytime you have pancreatic problems, you have to supplement with pancreatic enzymes, right, to help with digestion and stuff like that. So that's the main idea here. So these pills, this is a combo pill, pancreolipase, has amylase, lipase, and these proteases, which will help to augment the fact that your pancreas isn't working and secreting anything. All right. I wish I had more for you with the drugs, but it's kind of one of those things. The questions are, it's not that they're easy. It's just that they're straightforward when it comes to, like, they're going to ask you, this patient has this, what drug do you give? Or this patient has this, what's the side effect? Or this patient has this and there's a side effect, what drug do you give for that? So you kind of just have to go through it. Now, so now we'll get into the anti-diabetic drugs. And I'll tell you, I shadowed a internal medicine doctor, and when I tell you insulin regimens are such an art, like this is tailored, this is patient tailored stuff. Okay, so like literally the patient comes in, whatever, when they first get diagnosed frequently, and you're looking at their insulin or their glucose throughout the day, postprandial, just constantly to try to tailor these regimens. But it's very much a patient by patient type thing. But we'll kind of go through it on a simple basis here of what the idea is. So this is just kind of talking about, of course, type 1 diabetics aren't going to make insulin. Type 2 diabetics will, they're just resistant to it. Eventually, they kind of burn out their pancreas and they become insulin resistant or insulin deficient as well. Right. So yeah, let's get to the drugs. Insulin is 2 strands, and it's combined to C-peptide as well. So by breaking these bonds here, these disulfide bonds, you have 2 insulin molecules. All right. So we'll get to some of these drugs. Incretins are pretty interesting. They actively enhance insulin secretion, but there's some medications we'll get to in a little bit. This is kind of the process of how it all works, but we'll go ahead and get to the drugs. Insulin is a tyrosine kinase receptor. Right. So here's the idea. Okay, so in a perfect world, you can give somebody long-acting insulin. They could take it in the morning. It'll keep their insulin levels constant throughout the day. And unfortunately, the patient's going to have to eat, so you're going to get spikes in glucose, and you have to modulate those. So typically, what ends up happening, you give them a long-acting to control their basal levels, and when they eat meals, they take a rapid-acting to kind of prevent or help to modulate those spikes or bring it back down to normal. That's kind of the gist of how this is going to work. So you need to know the names of these rapid acting. So because it's rapid acting, you want to give it right before they take a meal, right? So you can give these when they take a meal, and that'll help with those postprandial spikes, okay? Subcutaneous injections, that's how you would give those. Okay, and then you have short acting, which again, my understanding, they give the rapid acting and they give the long acting. These are just different standards for them. Here, you can give these 30 minutes before a meal, but I think the only question that would come up is that this is what you would give in a hospital for emergency situations. Okay, so if there's anything to know about regular, it's that's what you give in IV emergency. Why? I'm not exactly sure. I get, that's what they give. Maybe they can give it. I mean, so they can give it IV in emergencies. I guess that's the idea. But when patients come in with DKA or whatnot, or if they're type 2 and they're hyperosmolar, their glucose is like 1,000. You can go ahead and give them this regular insulin IV. I'm sure you could titrate it properly, and you can kind of slowly bring down their glucose levels. So that's what you want to remember for that. But generally, when you talk about what do you give normally for a patient when they take meals, you give the rapidly acting. Now, there's also this intermediate acting, this NPH one. It's combined with protamine, but this is for basal control. But I'm not sure that this is really super important. I mean, if anybody knows more than me, I'm sure there's somebody out there that does here. Y'all could chime in, but my understanding is that you go with long and rapid. At least that's what I remember them teaching. So here are the long-acting ones. You need to commit these to memory as well. So you can give these once a day, and it'll help with the basal regulation. Okay, and the idea of the fact that they're bound as hexamers helps to slow the dissociation or slow the degradation of them. So it'll slow it down. So that's more of a longer acting result. Okay, and you can see this. I put a star here. I think this is a fair game for a question on a test, right? So you would expect these rapid acting ones to work here. Regular is a little slower, intermediate here, and then you can see these long acting hexamers that form here, okay, over a 24-hour period, okay? I starred this, but maybe just to know the names. I wouldn't really go into that too much. Protamine with intermediate action, yeah, P, I think P for protamine. I don't know what the P stands for. It might stand for protamine. Anyway, whatever. But anyway, short acting, emergency situation, intermediate acting has a protamine, rapid acting, give at meals, long acting, once a day for basal control. All right. Yeah, it kind of goes into how to make it work. Yeah, so this would be, you would give your normal one here. Yeah. Again, I think they're really just going to test you on the drug. So you can see this long acting, breakfast, lunch, supper, HS is at bedtime that you can give. So you do have this crossover. You don't want to wake up in the morning and that long acting wear off. So this will kind of cover you through the night. So you can actually take the long acting at night. Again, my understanding and in my limited understanding of this, like I said, it's so complicated, but you know, it's really titrated for the patient according to how their body responds to this stuff. Right, of course, with anytime you're providing insulin or injecting insulin, you need to worry about hyperglycemic episodes, okay? So if they take the rapidly acting, they need to eat the meal with it, right? You don't want to do that and then not eat, and then you get these hyperglycemic episodes and stuff, okay? Right, and you have to watch when you do, you know, causes of hypoglycemia, ethanol beta blockers, salicylates. Okay, so these can cause hypoglycemia. So diabetic patients need to be aware of this and certain medications that could cause hypoglycemia. I consider this low yield, but fair game. You know, one of the complications of diabetics that take beta blockers is that they don't get that response, that increased heart rate to hyperglycemic episodes. Okay, so that's a problem there. Ethanol, I'd say important, but yeah. All right. One more. All right, so now we're getting into the more complicated ones. Again, I don't think they'll test you too hard on these, just mostly like that mechanism of action and when you'd want to use it. So phenolureas, right? So these will decrease your plasma glucose, which is your whole goal, which will in turn decrease your HbA1c. So they directly stimulate insulin release from beta cells. So that's a good effect, right? So there's secretagogues that you can give there. Adverse effects, hypoglycemia, and weight gain there. So again, but it is important to note, like you can't, like you'd want to give these primarily to type 2 diabetics, right? Type 1 diabetics don't have working beta cells. So early type 2 diabetics, you want to give this to because you have to have working beta cells. All right, so this primarily works on this area, these potassium channels. You can see that I highlighted that here. Chloropropamide is this first generation one. You're worried about this hyperemic flush when alcohol is ingested. So it's inhibition of aldehyde dehydrogenase. And I don't know how super important that is, but of course, it can, hypoglycemia can be common because it is a secretagogue. It can cause insulin secretion. All right. Then there's the second generation ones. Hold on, let me think. There was something important about this. It had to do with these numbers. Cause hyperglycemia. Maybe it was just the fact that glyburide was more potent than these in this order. I think that's why I put the number 1 there, because it can cause hyperglycemia in 20 to 30% versus these with less. For some reason that, what's up?
I was going to lecture, they mentioned that it's most likely to cause hyperglycemia compared to glipizide and the other one.
Yeah, okay, yeah, I think that's why I put that there. So maybe it was IMCQ, maybe it was a test. They may have put like which one is most, just like you said, which one is most likely going to cause this hyperglycemia. So yeah, that's good to know. So in general, these second generations are more potent. Okay, so of course you're worried about hyperglycemia. The big problem here is weight gain too, right? In type 2 diabetics, you know, typically they have a problem with weight. So why, you know, idea of telling them to take a medication that's going to cause weight gain. It seems very counterintuitive, right? But we'll get there in a second with some of the better medications they could use. All right, and these are just a subset of these postprandial glucose regulators. So you can give these short acting, before each meal. Again, these are going to cause weight gain, but they won't have any sulfur component to it. Okay. I don't remember these being super high yield either, though. This is the big one, and this is kind of the first line drug, and it's just great, right? Because it's not going to cause weight gain. So metformin, I've listened to the podcast that there's a lot of off-label uses for metformin too. So if you're interested, it's pretty fascinating. They're doing a lot of research on it. But this does not cause insulin secretion or hypoglycemia, but it kind of pulls all of the glucose out of the blood. It inhibits gluconeogenesis, and it'll decrease your overall blood glucose, but it doesn't cause direct insulin secretion. Okay, so it can be used in combination with some of these other drugs that will work on insulin. But in and of itself, it's not going to cause this insulin secretion, which is great because it won't cause hypoglycemia. And also it doesn't cause weight gain, which is fantastic for these patients. Right, and so it's used very commonly. So knowing these things, AMPK, how it works, good stuff, right? Yeah, so it pulls it out. You can use it in the muscle and liver, get it out of the blood. That's a good thing. You don't have a lot of all of those side effects from all that extra glucose floating around, getting into your eyes, the distal nerves and all that, neuropathies and stuff. So, but you do have some side effects. Major thing in red here, don't want to give it to patients in renal disease, hepatic disease, primarily. So be careful with that. They do give questions about that because what ends up happening with diabetics? I mean, eventually, so you're on metformin and eventually you end up with renal failure. So eventually you have to take them off of metformin. Okay, so I've seen questions like that where these patients are on metformin and all of a sudden they show signs of increased creatinine and whatnot. So they're in renal disease, so you need to take them off of it. Okay, so be aware of that. That's the main thing I could think of. But good here that you're not gonna, it's not gonna cause weight gain. Okay, so I know even off-label they use this for stuff for weight control and stuff, among other things. So yeah. And then these glitazones, you can see these will decrease insulin resistance. So good for those type 2 diabetics. Here's a good just star this because I've seen this in questions. This is how it works on this PPAR gamma. So that's how it is going to work, and specifically with this gene regulation. But beyond that, I don't think it's super important. So you have to monitor liver function with these thioglytazone. Thiazoglytazones. And so these alpha glucosidase inhibitors, okay, so acarbose, it's a competitive inhibitor of glucosidase. So it'll help to reduce the digestion of these starch and disaccharides. Again, I don't think this is one of the first line things you would use, but it's there if need be. So help to drop your fasting plasma glucose and your HbA1c. But again, similarly to the last one, you want to monitor liver function. Okay, so you can see how it works here. This SGLT, right? It blocks that. And yeah, you can see here, right? So that's how that works. You won't digest some of these starches and disaccharides and stuff. All right, right. So again, if you don't digest them, you can get rid of them, and it will help to prevent spikes in your glucose. Okay, so this is an interesting one because incretins in and of themselves will increase insulin secretion. So it works as it's an analog of glucagon-like peptide, which will increase insulin secretion. Okay, so this can be used to do that glucose-dependent insulin secretion. Okay, so that could be used. It's very unique in that this is how it works. So exenatide, keep in mind, that's how it works, and its goal is to increase insulin secretion. Okay, yeah, don't use it with gastroparesis. Don't know that that's super important, but it's there. All right, and you can see this, enhance insulin secretion. Incretins, insulin secretion. All right. So, and direct, again, glucose stimulated insulin secretion. So the fact that you have postprandial large amounts of glucose floating around, incretins will help with that insulin. All right. Sitagliptin orally inhibits DPPIV, breaks down incretins. Okay, so this indirectly works at the same, similarly to the previous one. The incretin analogs, this will inhibit the breakdown of it. So if you inhibit the breakdown, you can help with glucose dependent insulin secretion, very similarly. All right. Then amylin analogs, again, I don't think this is super high yield. It inhibits food intake, gastric emptying, and glucagon secretion. Synthetic amylin, I don't remember any questions coming up for this. Right. Bile acid sequestrants orally. So if you do that, you can lower LDL, which indirectly will help with type 2 diabetes and atherosclerosis and stuff like that. Again, I'd say that's low yield. SGLT2, canagliflozin blocks SGL2, so you get decreased glucose reabsorption. Again, I'm basically reading out the slides. These are basic, very low yield stuff. I would just, if anything, just know how they work for these. And if there's a crazy side effect you need to be aware of, know that. Genital and urinary tract infections. Watch for patients with renal failure. All right, again, SGLT2, right? All right, here you go. Probably everything you need to know about this stuff right here. But by all means, metformin, sulfonylureas, exenatide, insulin, those are the main ones you need to be aware of. All right, and then it just kind of goes through the regimens. Again, metformin's great until you get renal failure, then you need to get off of it, okay? Yeah. It just kind of goes through what I was saying, like first line treatments, rapid acting with meals, long acting for basal control. Okay, in pregnancy, gestational diabetes or whatnot, go ahead and just give insulin. Just be careful, specifically lisinopril and aspartate. Give NPH, which is the intermediate acting one. Okay. And then, of course, the complications of diabetes. Remember, diabetic patients with heart disease, ACE inhibitors are a great treatment because they're renoprotective, ARBs as well. Statins, definitely give those, lower cholesterols. Aspirin will help with platelet formation. Yeah. Okay. And then the complications here, remember we talked about metoclopramide or erythromycin. Either way, I don't know one's better than the other, but you can give that for gastroparesis, specifically in these diabetic patients. Neuropathic pain, things like gabapentin are a good medication to use. And then stuff like Viagra, phosphodiesterase inhibitors can be used. Glucagon problems. Right, so opposite of insulin, you can see that heat, whoops. Sorry, just almost done. Let's see what they have to say. They're just, okay, so pancreatic alpha cells, obviously that's where glucagon comes from. You've learned all this, how they work. Yeah, you can give glucagon directly for hypoglycemic episodes, stuff like that. Yeah, don't think that's super high yield. All right, cool. That is all I got for you guys. It's been fun. Like I said, I'll be back down in Grenada next term studying for STEP. So this is super helpful for me too. So I don't mind doing this. If y'all have any questions prior to the exam, feel free to reach out to me. I'm done with school, so I'm kind of just hanging out at the beach and stuff. So again, good luck. Y'all are gonna do great. Enjoy your break. Have a Merry Christmas and be in touch.